Well, Brynhawn da and welcome, croeso to our board meeting, and we'll go straight into the agenda. Do we have any apologies for absence?
Yes, Chairman, this afternoon we've got apologies from Steve Moore, who's represented by Professor Phil Clare, Mr Andrew Crothers, Executive Director of Operations, who's represented by Mr Keith Jones, Director of Secondary Care, Mrs Mandy Riani, Executive Director of Nursing Quality and Patient Experience, who's represented by Mrs Sharon Daniels. We've also got Dr Joanne McCarthy, Mr Jonathan Griffiths and Donna Coleman, and Sam Denton is here representing Donna, and Dr Sean James is also here as Deputy Medical Director in attendance for the Medical Director items to support Professor Clare Chair.
Diolch yn fawr, thank you. So thank you to Phil, Keith, Sharon, Sam and Sean for coming and representing, much appreciated. Do we have any declarations of interest? No, okay. If we go straight into the minutes of the public meeting held on the 31st of March 2022, are there any matters of accuracy in those minutes? No, okay. If we go then straight to the action log. Thank you. I'm still wading through our papers. So the action log. I think Alison, you were going to give an update in relation to the West Wales Care Partnership Dementia Strategy and the palliative end of care. Or is that Jill?
That's Jill.
Okay.
But from a dementia, thank you, Chair. From a dementia strategy perspective, we did say that we would include discussions about that at the health and social care workshops that are being planned. But just to give some assurance that the implementation is already underway. It's very much a partnership approach with our local authority colleagues, and the work is actually already underway and being discussed through that partnership. It's been overseen through the Dementia Steering Group, and our partners are members of that as well.
Okay, many thanks. And I know Jill isn't here at the moment, but similar with the palliative and end of care strategy, and also the incorporation into the performance system and the BAF. Oh, you, Jill, excuse me, you are here. I'm sorry, lovely to see you.
Thank you. I think we've agreed that we will bring a further update to a future board on that, Chair. But again, just to assure you, as Alison has done, that the implementation plan is underway. We've had external funding to extend the external partner that's been helping us to look at how we implement our strategy. So that work is underway, and we'll be expecting to support the development of a programme manager to ensure that we actually do keep to the actions, because the implementation of this for our board is really significant, and it will mean a change in the way that we work to ensure that we put this in, embed this in place in the way that we intend to.
Many thanks, Jill. I think there's one other one, which is PM 2251. It's the quality of the job plans added to the SAS charter implementation, and progress will be monitored by the People Committee. Do we know when that will commence?
So, Chair, I can come in on that. There is an item on the People Committee about job in June where we'll provide an update, which will include an update on SAS job planning. And from June, we have a plan to work in line with the SAS Charter to consider the quality of the SAS job plans and undertake some sort of audit of those job plans, but will involve the SAS steering group in that.
Okay, many thanks, Phil. And then if we could move on to item 2.3, which is the minutes of the corporate trustee meeting held on the 31st of March. Are the board or the trustees happy to approve the minutes? Yeah, many thanks. Then go on to my report. All the details are in my report, but I'd just like to highlight a few points. Really proud of the rollout of the digital nursing care record. We are one of the first organisations to do this, and it will ensure consistent information about patients and improve patient safety. So many thanks to all the teams who've been working together to implement this. Also a huge welcome to Welsh Government investment, which has enabled a new state-of-the-art CT scanner at Glangwili. Not only is this a huge benefit to patients, but it's also good for staff morale. Similarly, the state-of-the-art ultrasound equipment at Withybush and at all our sites, mobile X-ray units for use at patients' bedsides. And I was fortunate enough to meet the radiology team recently, and they're so pleased to have this state-of-the-art equipment for our patients. And it's really good to see all the hard work to support our staff who are unpaid carers being recognised, with the Health Board achieving the Carer Aware Level 2. So again, a huge thank you for all the teams to enable this to happen. It's ongoing and it's such an important piece of work to support our staff. And as you can see in my reports, there are many awards outlined. And I'd just like to pick out a couple to congratulate Miss Chris Hayes, who was recently awarded the Chief Nursing Officer's Excellence Award for Nurse Staffing Level Programme. And in the UK National BAME Health and Care Awards, we've been shortlisted in 10 categories with 14 finalists, including the Achievement of the Year category for the corporate achievement. So I think we should be very proud of being shortlisted, and very proud of all our staff who've been recognised nationally. So I'm open to questions, colleagues, if anybody would like to raise any issues in my report. Paul?
Yes, Paul, you would like to...
Thanks, Maria. Not so much a question, because there's a request, I suppose. Under the Celebrating a Year Digital Nursing, obviously, and in the report, lots of positive stuff in there. I wonder whether it'd be possible for us to have a demonstration of the digital assessments that are referred to in that section, possibly at either at a board seminar or one of the appropriate committees. That would be perhaps interesting to see.
Sharon, shall I go over to you?
Sharon, you're on mute.
Excuse me, sorry. Thank you, Chair. Thank you, Paul. Yes, we'd welcome that. We've got a number of risk assessments. We've got the adult inpatient assessment and 5 risk assessments. So we'd be more than happy to bring those to a committee to demonstrate them in use. And just to note that they were developed by nurses for nurses, so they're very intuitive in terms of their use as well.
Perhaps Joe could pick that up.
Yes, Chair.
Yeah. Many thanks. Diolch.
Thank you.
So the board happy to accept the recommendation. Thank you. And there's a note in the bar from Hugh. We're organising a digital innovation week, and we will include the nursing care record in this, and an invitation will be provided to IMs, likely to be in September. So we'll coordinate that. Many thanks. And the next item on the agenda is the report of the Chief Executive. Over to you, Phil.
Thank you, Chair. And a few things just to highlight. I think the first that I wanted to highlight is the retirement of our Director of Public Health, Ros Jervis, recently in April 2022. Ros, we wanted to thank Ros really for her optimism, energy, enthusiasm over the years, and her positivity. She's made a huge contribution since her start time with us in 2017. And she showed huge dedication and commitment and drive in our response to COVID. In fact, that drive and commitment is one of the reasons we had such a good response to COVID. And I think the other thing to highlight is Ros's input into our Future Generations Living Well strategy, putting prevention at the heart, and I think her legacy will live with our communities for decades to come. So a huge thank you on behalf, I think, of all of us to Ros, and best wishes to her and her family. And just moving on to a couple of other items, I think the proposed new planning objective, which we're asking board to endorse. You can see that came out of discussions nationally with the Chief Executive of the Health Boards, Trust and Special Authorities, and this is additional an additional planning objective, additional work on top of the other work that we're doing around the urgent and emergency care work from the 6 goal work. So this this work is, I think, probably at an early stage of development. Andrew Crothers, Director of Operations, is working on how our plans internally, but we recognise that there's a huge amount of work to do in partnership with our key stakeholders, particularly our local authority partners, and we have plans to work really closely with them over the next couple of months in how we take this forward. It's going to be a joint, we expect it to be a joint response. This can't just be an NHS approach, and we really want it to be about community care capacity building, and we think, looking at our system and the challenges we have in the unscheduled care system at the moment, this could have a really big impact on our population. The other thing to mention is the Petitions Committee. It's referenced there in the report. The petition was discussed on Monday, and there's been a recommendation from the Petitions Committee for the petition to have a discussion at the Senate. So we will see whether that is agreed. And the other thing to highlight, I think, is the cost of living report, because recognise how difficult it is for our whole population at the moment, given the rising costs of living. But this task and finish group is particularly directed at our staff, and Lisa Gosling is leading that and looking at what we can practically do to help our staff in these difficult times that we're going to experience over the next year. Thank you.
Many thanks, Phil. Does members have any questions or any comments? Gareth and Derek.
Thank you, Chair. Yes, it is very reassuring, Phil, to hear you there stress the need for partnership working when it comes to increasing the capacity of community care. The proposals there are very significant. Talking an average of 120 per day, for instance, within Hywel alone. So not so much a question really, but just seeking reassurance that the engagement will take place with our local authority partners and third sector and wider partners as soon as possible, because now it's being discussed there. The devil's always in the detail, and happen to know there's an awful lot of work that needs to be done, but the principle is sound. Just the reassurance that work is already underway to make contact with our partners.
Thank you, Gareth. Shall I go to Phil or straight to Jill?
Just to say a brief comment from me, which is it's an absolute prerequisite of this work being successful that we involve our local authorities and third sector within this. And Jill will want to come in, I'm sure.
Jill.
Yeah, yes, thank you. And I think we actually, as a partnership, all welcome this, because it really does place at the centre of our strategy this important focus on our primary and community services. And this is an ongoing discussion that we've been having for many months, if not the last couple of years, in great depth actually with our partners through our integrated executive group and also through the regional partnership board. So I think this allows us to concentrate a level of focus in terms of our delivery and our expectations, but it will really build on the work that we've done, and particularly over the last few months, in terms of how we've together tried to approach the challenges, particularly around things such as domiciliary care. So the other important thing that I would want to stress here, it's actually how all of these objectives work together, because if we end up focusing on something in a narrow silo, we miss the context of that whole element of delivery and the interface between things such as urgent and emergency care, our home-based care, our vaccinations, and all contribute actually to our ability to provide that capacity and level of service that we need to within our community services. So that integrated, joined up approach with that comprehensive understanding across all of our boards is really important in terms of taking us forward.
Many thanks. Dydd.
Prynawn da, thank you, Chair. My question's in relation to the cost of living impact on both our staff and our patients and carers. And do we know if a number of our staff, especially lower grade staff, have been adversely affected, and are we seeing a reduction in our staff numbers because of this? And then the second part of the question is the impact on our patients and carers and families, and in regards to their travelling to appointments or treatment. Do we, is there advice that we can give that client group, or are we seeing a reduction in attendance at our departments because of this? Thank you.
Thanks, Dydd. Lisa.
Thank you. To answer the first part of your question, Dydd, we haven't particularly seen a decrease in our workforce as a result of the increase of cost of living. What we have seen is areas where people are requesting more flexible working so that they don't have to travel into work every day. So that's part of the action plan that we have around hybrid working. The second thing is that we have noticed a decline in the number of applicants for our apprenticeship programmes. So whilst we have still got a very good number, they are less. So we are looking at the rates of pay linked with the apprenticeship because it could be making a difference. So that's the update in terms of those things. Unless there's anything else for me, I'll hand over then to somebody else for the patient element.
Thanks, Lisa. Would anybody able to pick up the patient element?
I'm happy to speak from a primary care perspective, Chair, and you'll know that over sort of COVID in particular, we developed remote means of consultation for patients, and all of those arrangements are still in place actually, and it's where necessary and appropriate that individuals will have a face-to-face appointment, and also that will be at the request of patients but also clinicians, but all of the remote opportunities remain in place which will hopefully support individuals in terms of reducing the need to travel. And there are also virtual appointment arrangements within our secondary care system as well, and that's been developed over the last few months.
Thanks, Jill. And I think we all have a fear about the impact on people's health generally as a result of the impact of the cost of living, both their emotional, mental and physical health. Thank you. Any other questions on the Chief Executive, on the report? Okay, thank you. If I could just reiterate on behalf of the whole board, a huge thank you to Ros, a phenomenal Director of Public Health and a beautiful human being who's given so much to this health board at such personal cost and sacrifice, particularly during the pandemic. So we all send a huge thank you to her. And in respect of the new planning objective, just to re-emphasise that we are totally committed in doing this together with our partners across the 3 local authorities and the 3rd sector. And Gareth, we'd welcome giving you a briefing, more of the detail about how we are connecting with the local authorities and to take your advice as well. So thank you very much. Everybody happy to accept the recommendations of the report? Diolch. Next we go on to the Audit and Risk Assurance Committee.
Thank you, Chair. 2 reports, as you know, at this time of year, audit committee meetings come thick and fast. The report for the first meeting is the meeting of the 19th of April. You'll see the report sort of speaks for itself, but you'll see at the end of the report there were 3 issues or matters that we were asking board consideration or approval for. Declaration of registering of interest, that's effectively just highlighting the fact that it's work in progress really so far as developing and maturing that. But then 2 issues which have previously been before the committee on a couple of occasions really, and the feeling in the committee was that we'd probably gone as far as we could in sort of overseeing the work which was being done on these 2 issues and suggesting that they now be passed to 2 other board level committees for ongoing scrutiny.
Thanks, Paul. The chairs of those other committees, Quality, Safety and Experience and Sustainable Resources, happy to transfer the consideration of radiology and records management? I take silence as a yes. Yes. Thank you, Anna. Thank you, Winston.
I think yes.
Both.
Yeah, yes is definitely the right answer, I think.
Thank you. I think about when we're doing everything virtual, we have to take every silence as a yes, you know. Are there any questions on the first report from ARAC? No? Okay, Paul, do you want to go on to the second?
Yeah, so the second one is from the meeting of the 5th of May. Again, the report details the work which the committee undertook at the meeting. Again, some of the issues which are at this committee are issues that we've sort of dealt with for some considerable time. At the end of the report, again, there are 3 matters where we're asking for board's consideration or approval, which are really all part of the year-end process. And then I just feel I probably need to highlight the position with regard to women's and children's. We've obviously had some discussions about this both in the committee and at board level on a number of occasions. I think it would be fair to say that we recognise the work which the team now within Hywel are doing to try and manage this in the best way possible. My comment would be, how do we get from here to the conclusion of the contract? Your preference would be, well, we wouldn't start from here. So we're in a difficult situation with the management of it. We're doing probably all that we can. There is one issue that we need to resolve, which is the completion of the parent company guarantee. And I understand that that's work in progress, which anticipated should be done by the end of June, and we'll obviously be having a report on that at the future audit committee.
Yeah, thanks for raising those, Paul. And I know the Chief Operating Officer is fully aware of all these issues as well, so thank you. Any questions or comments on the second meeting of ARAC? I have one question in relation to the self-harm, prevention of self-harm internal audit, and it's the reference on page 2 to the alternative audit tools such as the AMAT tool, which is currently being piloted within Hywel. Do we have any idea when the pilot will end and when it will be rolled out? Sharon, is that you that wish to come in?
Yes, please, Maria. Apologies for the background noise. Yeah, the AMAT tool was procured within the Health Board for the end of February of this year. It was primarily procured to be used for clinical guidelines and clinical audit modules. However, its functionality can be extended, and that's where we began the conversation of whether we could extend that to wider to incorporate inspections and health and safety audits as well. It's a powerful tool that relies on end unit ownership, so people have already made the connection. I think that it will be a useful tool for tracking specific audits and legislative compliance. So I'm just waiting for a timescale now back from the Health and Safety team. There are a few adaptations they need to make in terms of building the questions they want to use into the tool, but they certainly feel it is something that they can use going forward. So I shall pick it up outside the meeting, and I shall inform you in terms of timescales and when that could likely happen, if that's okay.
That's lovely. Thanks, Sharon. We put that in the action log so we can have it fed back to the next board. Thank you very much.
Chair, that because of the rating on the report, internal audit will be going back and reviewing this area as well. So that'll be something that they can pick up as part of that process as well. But that'll be some further time down the track, basically. Yeah.
Thank you, Paul. Well, thank you very much, Paul. If we now go on to the Quality, Safety and Experience Committee.
Thank you, Chair. So this is a report from our meeting in April. It is a thorough account of the discussions that we had, and particularly noticing the value of the deep dive items that we have begun to take on a cyclical basis through the committee. So I have nothing to add to the report and happy to move straight to questions, Chair.
Thank you. Can I open for questions, please? Dydd.
Diolch, Chair. It's in regard to the Welsh language provision for our school nurse and youth health team. Is there an issue that we need to be aware of? Are we actually enabling our young people to access our school nursing team in the proper manner that they would prefer the language of their choice. Thank you.
Sharon.
Thank you, Chair. Thank you, Delyth. Yeah, the requirement for Welsh language for a school nursing role has impacted in terms of the ability to recruit into them, because the majority of schools across the Health Board are Category A Welsh speaking schools. It isn't solely an issue in one county alone. It's not an essential requirement for all the roles for the staff to be able to speak Welsh. However, we do feel that they feel that they need to improve their language skills to be able to speak fluently in their roles in the schools. So we're reviewing the school nursing service as a whole anyway, and we will also be capturing the voice of the children as part of that to see what in which language they want to be communicated with. We do have access to translation services and also some IT technology in terms of translation apps, etc. And we are linking with educational leads and the local authorities as well to ensure that we can work together to overcome those challenges. There's plenty of opportunities in terms of training for Welsh language, which does provide those conversational skills. Sometimes, as I said, staff feel that they lack the confidence to use that. So what we're looking at is whether they can overcome this by introducing a buddy system so they can work with a peer who does speak Welsh, just to, and also, as you've probably heard in previous meetings, we're focusing on a grow your own approach to staff the service going forward, so that we will already have people coming from our Welsh speaking communities to work within the Health Board.
Thank you, Sharon. I've got a couple of questions in relation to page 5 of the report. In relation to the epilepsy and neurology in learning disability services deep dive, it says that correspondence outlining the development will be issued to the families concerned. I just wanted to confirm that these have now been issued. I think, you know, one of the issues for us is to ensure good communication, and the other one is in relation to the maternity services improvement plan. Follow the inspections, and also the CHC did a survey in relation to maternity services, and will that be taken into account at the same time as part of the action plan, which will come back to the June meeting? And then the last one was the review into the Community Health Council response. Sorry, the review looking at the care packages that we commission, and what's the date for this review being completed? I don't know who would like to take those.
The Chair, I'll start with the first one, and I'm sure Sharon and perhaps Jill might want to come in on the second, third. So the first one, which is about the correspondence to families. My understanding is that correspondence has taken place, and we've also been in touch with one of the third sector organisations to identify if they have contacts that aren't on our original list, that we were going to cross-reference those lists. I need to check with the Director of Operations, and I'll do that, of course, in between the boards, and get that assurance back to you as Chair.
Thank you.
My understanding is they have gone out. On the CHC, certainly that will be taken into consideration to the review. I just wondered whether Sharon had any further other detail on that, but it may be simple to say yes, it will be, of course, taken into account and must be. Sharon, do you have anything to add on that?
Sharon, you're on mute.
Sorry, no, nothing to add. Of course, it will be taken into account, Chair, and I think it will form part of the deep dive in CUSEC in June, and then it'll come back to the part of the board paper then in July. Thank you.
Many thanks. And then the commission services for the care packages, the monitoring of care packages. Jill?
Thank you. I don't yet have a timescale in terms of the conclusion of this particular review, but just to assure you anyway, Chair, and to assure the board that we have a number of reviews ongoing at this point. Later on, we've got a paper which sets out the new CHC framework anyway, but in particular where we have examples such as this, where there may be a lack of clarity around responsibility in terms of the Court of Protection or mental health services legislation, we review those cases to try to identify a clear process in terms of making sure we get that right going forward. So I'm happy to report back at the next board and our next QSIAC meeting in terms of providing that further update.
Many thanks, Jill. Thank you, Anna. If we now go on to the next paper, which is Improving Patient Experience Report. I think that's probably Sharon.
It is. Thank you, Chair. Just to say in summary, this report takes us up to the end of the last financial year. Going forward, there is a proposal to review the format of the report and the information that's provided within it, which will be enhanced by the new Civica system. The transition to the new system is expected to conclude by the end of this month. However, training will continue to be delivered to operational teams to ensure that they have access to the system and can pull the necessary information to assign the actions and the learnings. Just to note that this system does give the directors the ability to access data in real time, and it will enable them to set trends and alerts so that they can monitor feedback on an ongoing basis. So we are anticipating some more analysis opportunities and more outputs once the system is embedded. Today's report aims to demonstrate that we are continuing to capture service user feedback in various ways, and it started with the patient story that Maxine shared with her, and sadly we have failed to meet Maxine's needs when she visited our facility in Prince Philip Hospital, and I must apologise for that. It fell short, and one of the actions that's written in the report is that our patient experience team has linked in with a diversity and inclusion team to arrange more training across all the sites. However, I think training and education, although extremely important, can only be facilitated by the culture in which it's delivered. So I have spoken with the deputy head of nursing in Prince Philip Hospital, and they've already started to undertake some work with our people culture team, our relationship officers within Lisa's team, to look at that in more detail and to understand so that the training can actually be as effective as it possibly can be. I want the report is there. I'm happy to take any questions.
Thank you, Sharon. In relation to the story, will that be used as part of that training? Because it's very, very powerful.
Yeah, you're right. It is very powerful, and we have used stories in the past to drive that improvement and to raise that awareness. So yeah, we certainly will use that story and share it not only with the staff in the area that Maxine attended, but also wider across the organisation as well, so that we can learn lessons from this in all areas of the health board.
Thank you, Sharon. Any questions on the patient experience report? Sam, did you want to come in?
Yes, please, Chair. If I may, really welcome the report and the light that it shines, and the attempts being made to improve patient experience. Just from a CHC perspective, we've been receiving feedback via national survey, a range of topics that we feed back to you and the Welsh Government on a regular basis. Some of those experiences have focused on urgent care settings like ED, emergency departments, A&E, and some of those have revealed some pretty grim issues around those experiences. And the vast majority of these experiences have been affected pretty dramatically by COVID. And I think many of the public, not necessarily all, have kind of stoically accepted this. And we all hope for gradually improving picture in coming months. So accepting the unique challenges that the pandemic has brought and the commitment of staff, what assurance can a health board give the public that learning is taking place in these settings such as ED, which regardless of the pandemic will continue to experience periods of really intense pressure and high demand at different times?
Thank you, Sam. Sharon, did you want to respond to that?
I can, Chair. In terms of, for example, the review of the paediatric service, because I think that featured within the report. I know that we have a standard operating procedure now, so that, you know, to make sure that any children coming into the A&Es are triaged and taken to the relevant paediatric area to release the pressure on the A&E, but also to promote the patient and parental experience as well. So we're also ensuring that the paediatric advanced nurse practitioners are involved in the daily huddles in A&E, and we've altered the hours that they're working from 12:30 to midnight so that we can have a presence there you know, during the day at the right time. Similarly with the enhanced consultants.
The learning there. So Lisa, I wonder if you could expand on that, please.
Yes, certainly, Chair. So our customer care training programme, Making a Difference, is now live, and we have got members of staff who are booked on for the next few months who are attending that. So the focus of it isn't the traditional learning style that we have adopted in the past. It is around how do you make a difference to our population, to our patients, to your colleagues and to yourselves. And the feedback that we've been getting from people is it's just an open place where they have a discussion around the impact that they can have on someone's experience without realising it. So there's a number of people who have been through that programme who have said, I know I need to try harder. And it, you know, even if I'm having a bad day, that's not anybody's fault. So it's early days of that programme. I think we're on our third session so far. And we will be bringing an evaluation report back to our people committee in terms of the impact that it's had on staff.
Thanks, Lisa. Now if I bring in Sean.
Yeah, I just wanted to give assurance around the way we learn lessons from when things go well and when things don't go so well. So we provide a bulletin to our primary care providers regarding incidents and things that can be learned from, so that there is a true learning happening within this organisation, so that we learn from when things go wrong. We put things in place so that things are better the next time, so that we really close that loop on concerns and incidents properly, so that we've got a learning organisation.
Thanks, Sean. If I could add as well, as you quite rightly say, Sam, on behalf of the CHC, and as we all know, the pressures on unscheduled and emergency care are unprecedented at the moment, and they come after 2.5 years of the most challenging time for any of us in the NHS. And some of the other things, such as the planning objective that was in the Chief Executive's report, which is to help frail people who shouldn't be in hospital be cared for in the community. We've got a programme shortly transforming urgent and emergency care for senior clinicians and decision makers to come together, because as well as impacting on patients, it's also impacting on the anxiety and stress of our workforce, the pressures, and you can see in the performance report, you know, the how people are presenting, sicker, etc. So we are addressing it at every single way we can, but it's, you know, it still isn't good enough for the public or indeed for our staff. But we're doing our very best, and then I'd like to say on behalf of the Health Board apology as well to Maxine and to other people in the community who wait too long in our A&E and don't have the type of experience that we so want them to have. But we are doing everything we can within our resources to try and make things better. So thank you. Are there any other questions on the patient experience report?
I've got Judith.
Sharon.
Jill.
Thank you. Judith.
Yeah, thank you. One is a question, one is a comment. So my question relates to the pet therapy, and I would like to know whether any sort of plans to expand that beyond the ward at Withybush. The comment is about the arts in health. I have the pleasure of attending the nursing midwifery conference last week, and our artists presented and particularly talked about the work they were starting with the child and adolescent mental health service, and it really was fantastic. They've achieved so much in such a short time, but I think they gave us some work to do, but they really did raise the spirits in terms of what they did. So I just wanted to comment on that, but also a question about the pet therapy.
Can anybody respond to the pet therapy? If not, we will take it offline and get the detail. Okay, thank you. I think Phil wanted to come in, and then Sharon.
And Delith as well, actually, so you might want to bring Delith.
Okay. Delith.
You're on mute, Sharon.
Technology is being an absolute pain today. We apologise from Abereiron. I think Sharon wanted to respond to the pet therapy question first, okay, and then I'll ask. Thank you.
Please come in, Sharon.
Yeah, only briefly, Maria. I was just going to say that, Judith, there certainly are opportunities for extending that service, and I know for many years, from an infection prevention perspective, we've been facilitating visits, you know, but I think it's definitely something we need to explore further offline and then bring back to you then, Maria. Chair.
Thank you. Delith.
Thank you. I've got two questions, if I may, and I'm not sure who can answer them. One of them is about the paediatric feedback as well, and the importance of play specialists. We have play specialists in our inpatient paediatric wards, but is there any option to provide some play therapy in our A&E, for example, or ED? Because I'm sure that they could help alleviate some of the anxiety and distress that our younger patients may be presenting with. So that's one. And the other question is about, unfortunately, about the mental health and capacity comment from one relative. And do we provide mental health training to all our ED and CDU departments? Thank you.
Thank you, Delith. I wonder who could take that question.
I can try and, I think, Delith, what you're referring to is Mental Capacity Act training, and there is a rolling programme across the Health Board in terms of that, and our Mental Capacity Act team also undertake audits in terms of looking at records and trying to ensure that that capacity issue had been appropriately followed in terms of determining capacity appropriately, but also not just assuming that people haven't got capacity, but we do go through that proper process with all staff, and that rolling programme exists across the Health Board.
Thank you.
Keith Jones has suggested he can take the play therapist question.
Thank you. Come in, Keith, please.
Thanks, Chair. Thanks, everyone. Yeah, I can take that issue back to the Women's and Children's Directorate team and just get some clarity on their future expansion ambitions. Dennis is quite right. We don't have them within the ED environment right now, but clearly that's something we need to explore.
Thanks, Keith. And if you look at the paediatric paper, which comes later on with all the feedback, it's an ongoing theme, the experience in A&E. Ideally, we'd like a separate A&E for children and young people. But if we can't, we need to make the one that we've got as user-friendly as we possibly can. So thank you for that. I think the next person who wanted to come perhaps was Jill.
Yes, thank you. And it's going back a little bit actually to the point at which Sam was referring to in terms of access and experience. And it was really just to add to Sean's comment that as part of the contractual regulations now, we have to have an access standards committee. There are also access standards that each of our contractors have to attain. So that's monitored through that process. And the CHC are part of that access committee along with the LMC, health boards and others. But also, and Sam hasn't raised it here, but we know that we're going to be bringing back to the relevant committee the report that CHC members have recently undertaken across general practice. We're working through those reports now and the comments, and whilst it was undertaken during COVID, we know that some experiences were not as good as they could have been, but other patients did report positive responses. So we're working with the CHC now in terms of the pre-publication period, but those will be in the public domain, and the lessons, as Sean alluded to, will be taken through all of the opportunities in terms of communication with primary care and our relevant health board committees.
Thank you, Jill. And I think Phil wanted to come in as well.
Yeah, it was on the same point, just going back to Sam's points earlier and questions. I mean, I think, like you, I'm really sorry for the experiences that people are having trying to access our services at the moment, which are under so much pressure. And, you know, there's some really difficult experiences for people. And I suppose I agree with you that I think in part it will be about how we influence the culture and improve staff training and support our staff into providing a better experience for people at the front door. So the customer care work, the work Sean was talking about with GPs, but I guess the other part of this will be all the work we're doing creatively to look at improving the system just in the way it works, so that the system our staff work within works for them to provide much better care and experience for our public. And that's why some of the items later, I think you can't split them from having an impact on what the kind of care that our staff can provide.
Thank you, Phil. Are there any other comments or questions? Well, many thanks, and the board's happy to accept the recommendation. And a huge thank you to the patient experience team who have given us the voice of our patients each board meeting over the last few years when we haven't been able to have people here. So many thanks. Next item on the agenda, 3.2, is the Nurse Staffing Levels Wales Act Annual Report. And Sharon, that's you again, excuse me.
It is. Thank you, Chair. It's quite an extensive report. It introduces the Health Board's annual assurance report and covers the period from the 6th of April 2021 to the 5th of April of 22. You note from the report Section 25B of the Act was extended on the 1st of October last year to include, in addition to adult medical and surgical wards, paediatric inpatient wards as well. As you're aware from previous reports, the Act has 5 sections, and those are detailed in the background section of the SBAR. And also to note that the All Wales Nurse Staffing Levels Group has produced the template for this annual assurance report to facilitate consistency in the information that's collected across all NHS boards in Wales. So this is what we have used to collate the information, and is contained within attachment 1 of the report. Although the primary function of this report is to provide assurance around those wards where 25B of the Act applies, the Health Board also has a statutory duty under Section 25A of the Nurse Staffing Level Wales Act. So for this reason, we've included an additional section in Section 16 of Attachment 1, which is a summary of the wider work that's been undertaken in relation to those areas during the last year. For ease of reference, the report identifies key priorities to note from the detailed narrative that's included in the attachment, and that includes reasons for adjustments to the nurse staffing levels and also information on serious incidents during the reporting period. You'll see from the report the planned roster remains challenging, and it is to the enormous credit really of our operational managers and our clinical staff that they have this has been managed with very limited impact on the care quality indicators during this period. The paper also provides assurance and to confirm to the board that the Health Board met its 3-year statutory reporting requirements under Section 25E of the Act, and that the 3-yearly annual assurance report was commended by Chief Nursing Officers for completeness and detail. I won't go any further, Chair. Just happy to take any questions. Thank you.
Thank you, Sharon. Really good summary. Any questions? Well, a comment I have, it was really good to see the commendation reflecting the amount of work that's been done in a very challenging area. Paul.
Thank you, Chair. Yes, obviously excellent report, and good to hear about the positive recognition that it received recently. My question really is about, obviously, the remit of the Act poses significant challenges for the Health Board, and my question is really, how confident are we that we're going to be able to continue to meet the challenges of the Act, and if there are further extensions to the Act, how we will be able to address those extra requirements, particularly given the challenges we face both with retention and recruitment.
Thank you, Paul. You may be aware that the Health Boards in Wales received a letter from the Chief Nursing Officer on the 14th of April, who, when she was reflecting on the publication of her priorities on the impact of the pandemic, felt that it's a natural point to pause and reflect on the approach taken up to now by the All Wales Nurse Staffing Programme, and to set the direction going forward. So she's decided at the moment not to publish the mental health, the district nursing and the health visitor principles for the time being. However, within the Health Board, we are continuing the work in relation to 25A, as I've referenced in the report, and we continue to prepare our teams to utilise that triangulated methodology in terms of acuity, quality indicators and professional judgment, so that they're familiar with the process that enables compliance with the wider requirements under Section 25A of the Act. We continue to have strong representations in all Wales levels on all the work groups. In fact, our Director of Nursing is the exec sponsor for the mental health principles. And we continue as a Health Board to focus on the team around the patient model, which, you know, isn't going to be a quick fix, but we are reviewing every area and considering this modelling as we're having those conversations with the ward managers. And this year the difference is that in addition to the heads of nursing, we've also got the ward managers in those nurse staffing calculation conversations as well. And until that time, we continue to take all reasonable steps to make sure that we meet the needs of our patients, and we monitor the impact of the care that we provide through our care quality indicators, but also our workforce indicators as well. Thank you.
Thank you, Sharon.
Thank you, Sharon. Are there any other questions? Okay, thank you. So the board's happy to receive the assurance report as a source of assurance and to accept the recommendation. Thank you, Sharon. Thank you, everybody. The next item on the agenda is the Transformation Steering Group update, and that's you, Phil.
Chair, so this paper is a helpful reminder of the role of the Transformation Steering Group, which is set out in the paper, and outlines some of the work that's been going on underneath the auspices of the Transformation Steering Group, particularly relating to a planning objective that is one of my objectives, which is around the social model of health and well-being, which is the key underpinning principle of our strategy. So this work has been developing over the last 8 or 9 months. 2 particular strands of work. One of them is a systematic review of the literature that Aberystwyth University are undertaking for us, and the other part of the work is a series of conversations with thought leaders and opinion leaders from across public life, whose insights and perspectives are being themed by the Public Health Wales team. And both of those then will be brought together into one report. And the idea is to help us understand more the term a social model of health and wellbeing, and also help us understand what the NHS's role might be in helping us move towards a social model of health and wellbeing. We're planning further engagement with the PSBs and RPBs, as you can see in the paper, quite shortly, and that which should help inform what further engagement we do with partners and citizens who live in this area, and potentially with partners outside Howell VAR. As part of the work, we proposed a new planning objectives, which was being shaped at the time of writing this report, has been taken to our executive team, and that will be taken through our assurance committees. But it's a progress update on the work of the Transformation Steering Group. I'm happy to take any questions.
Many thanks, Phil. Can I open it to questions? Okay, well, as a member of the Transformation Steering Group, I had the benefits. Grand. Maynard, come on in.
Thanks, Chair. Yeah, it's just really in relation to that new planning objectives. You've answered part of my question already, that it's one that you're leading on, Phil. I was wondering which director was leading on it. But I'm wondering what are the timescales of getting that planning objective together, and where will it sit in terms of governance going forward? Which committee?
Yeah, thank you, Maynard. So the planning objective has been to executive team last week, so it's very recent. The proposal, I think, will for it be to be under the same committee as the social model of health and wellbeing planning objective, and because it's the same territory of work, which is the name right, looking to Joe. SDOC.
Maynard's committee, Strategic Development Committee.
Thank you, Strategic Development Committee.
Thanks, Phil. Just know that this was coming my way.
Thank you, Maynard.
Thanks.
Thank you. Anna, did you want to come in?
Yes, please, Chair. Phil, I wonder if you could perhaps give us an example of something that we're learning through this process that we didn't already know. What's coming up that has perhaps struck us as being particularly interesting?
Yeah, that's a really good question. I suppose a few things, general things have struck me. One is that just how much enthusiasm there is for us to move towards a social model of health and well-being, and how much of an urge there is from people from all sectors for us to move into the territory of a social model of health and well-being, and not just confine ourselves to a purely biomedical one. That's not to say that the biomedical model isn't important, because actually, as we've just been talking about, there's a lot of people that need care and highly specialised care. However, I think there's a feeling that we should be, that from all partners, and that they would want us to move into that space. I think the other thing that we're learning is that the amount that they want to themselves commit to work with us within this. Now, I think I'd have to caveat that with saying that we've only spoken to a certain amount of people, and there's a lot of partners locally that we need to speak to determine how much they would want to commit to this work. And I think that is the work over the next 6 months to a year. I think the other thing, I mean, whether this is something that's new or has re-emphasised something that we already knew, was that there was a real push for us from everybody to focus on inequality and the next generation. And even if we were to think about it through the lens of the family, to focus with a mind of the next generation and life chances. And what that led me to do was to look back at our standing orders, and it actually, in the very first point in our standing orders, I happen to know this, I read it at 1.0.1, it does tell us our responsibility is equal on around improving health inequality and population outcomes as it is around providing care. And I think when you look at the balance of our agenda, it is balanced much more towards care than it is reducing health inequalities and prevention health promotion. And I think that's something that we need to think about as a board. Clearly, we've got huge challenges in providing care, and we can't take away from that. We've got a lot of work to do on that. But I think the social model of health and wellbeing work will help us balance our thinking and attention.
Thank you, Phil. I'm going to bring in Ewan and then Judith.
Yeah, thank you, Chair. And again, thank you to Phil for the paper. You'll recall at TSG, I did kind of note my disappointment at the consultation that was undertaken, even though, yes, it's been framed as a thought piece on obviously the work within communities. I was disappointed that less than a fifth, I think, of those people who were consulted were within those communities which are in the Hywel Dda area. There were people from elsewhere in Wales who was very influential and experienced in their fields. I felt, and many others, had no direct kind of correlation or connection with our communities here in West Wales. I know we had a kind of debate in terms of obviously reconfiguring to make sure that as we go forward with this, the community voice is absolutely critical, and it should have been on reflection, grassroots led, rather than kind of a thought piece from those who live far away from our community in Hywel Dda. But I just want to say I very much welcome within the paper the kind of emphasis now going forward on engaging with at least one community in each of our counties here within the Hywel Dda footprint to now look at getting that direct grassroots kind of evidence in to really kind of help shape and inform where we all obviously want to go collectively working together on this, and look forward to seeing that as it evolves.
Yeah, thanks, Ewan. And I do recall that a few discussions we've had about this, and I do understand where that comes from. And of course, this has to be relevant to our communities and community-led. That is the whole essence of the social model for health and wellbeing. I think one of the things we felt was important was to do some exploration ourselves to try and understand, get our thinking right. Is this a term that people would support us on? And I think when we go into those discussions with the PSBs and RPB membership, we'll be in a much stronger place to be thinking about how we would do that engagement with the communities than we perhaps would have been if we hadn't have undertaken the thought leadership piece. But I think the premise of what you're saying, I completely agree with.
Thanks, Phil.
Thank you. Can I bring in Judith, please?
Yeah, thank you. I think my question is about linkages, and you mentioned in the paper about presenting to the PSBs and the RPB, and I think it's just important to think about linking to other programmes, and I'm referencing particularly the accelerated cluster process, because quite a lot of what is in discussions about social model of health is starting to come into the remit of those pan cluster planning groups. Sorry, I do struggle with that, and the accelerated cluster programme. And mindful that the RPB had a presentation on that, I think to make those links about the work of those cluster groups in the counties and how they can be part of this, and the members can be part of this, which does include local communities, third sector groups, as well as our primary care partners. It would be good to make those links.
Maybe if I know Jill will want to come in, but I think it's early days of the exploration of the social model health and wellbeing, and Jill and I have spoken about this, that what we didn't want to do is there'll be other pieces of work as well, which we wouldn't want the social model health and wellbeing to disrupt the programmes of work that are already in place. And I think now we're getting into proposing new planning objectives. It's absolutely the right time to make those linkages. as you say, and there'll be some work from the public health team, there'll be other work through the IEG, through the transformation programme projects, which are really relevant to this, and other work through the PSBs, you know, on child poverty, that's very, very relevant to this. But Jill, I know, Chair,
thank you. And thank you, you've made those important links there, Phil, and I know that we will work together on this in terms of ensuring that we've got that interface, because the expectation around the pan cluster planning groups is that they will have that oversight across a range of resources and groups and communities to provide services for their whole population based on the population needs assessment that has been undertaken through the RPB, and respond to that. And programmes are then commissioned in accordance with that delivery. And what I'm sure we will do, and because we already have a lot of work going on with our communities, is to use the vehicles that we've got already to deliver some of these combined objectives, so that we don't conflate things or create unnecessary programmes and groups, but we utilise the services that we've got there. There are other objectives also, such as 1D, where we are looking to listen to our to our communities, to work with them in terms of empowering our community voice as well, particularly around the management of their own health conditions, which also would relate into this. So I think there'll be further discussions, as Phil said, in terms of how we draw this together, but I will want to see that the pan cluster planning groups have got that level of oversight and commissioning in terms of helping us move some of these things forward as well. And I know we're going to be bringing further work through a board seminar to explore some of that infrastructure in more depth, and then how we bring things together.
Thank you. Well, I think the level of debate is really exciting. We know it's the way forward, it's how we do it. So thank you, Phil, for all the work you're doing in this field, and thank you for everybody's valuable comments. And we look forward to it progressing. So the board's happy to note the information from the Transformation Group update. Many thanks. If we now go on to the Implementing the Healthier Mid and West Wales Strategy Programme business case, over to you, Lee.
Thank you, Chair. Yes, so the paper gives a high-level update on the work that's been going on to progress the Healthier Mid and West Wales strategy following submission of the business case in February to Welsh Government, which board endorsed in January. We've had, as the paper notes, we've had some scrutiny comments back from Welsh Government since the last board meeting, and we've provided detailed responses to those. The paper does identify that we were due to have the Infrastructure Investment Board this morning, and it says that I would update verbally. The date changed a short notice for that, so that's now going to be tomorrow morning. So we will update board at next board seminar and formally in the next board meeting on how that has gone, and any further information we get from Welsh Government formally following that. The paper particularly gives an update on the technical appraisal criteria that we're using for the land selection, which we're looking for board endorsement for today. And we held the first workshop on that process yesterday, which I'm happy to give a verbal update on, Chair, if you'd like me to go into that. We've also been progressing the other appraisals that we've got in relation to that. The financial economic appraisal, the workforce appraisal and the clinical appraisal, and each of those are progressing as per our plans, with the intention of producing all those outputs for the board discussions in early August. And then finally, the paper gives an update on the work that we're doing around communications and engagement, recognising that this is obviously a very critical interest point for the population, and our determination to engage with our public and stakeholders as we develop the plans over the coming months and years. So I'm happy to take questions at that point, Chair, or give a verbal update on the conversation yesterday.
Lee, would you mind giving a verbal update on the conversations yesterday, and then we can go to questions? Many thanks.
Yeah, no problem. So yesterday was the first of two workshops on the technical land appraisal. We're doing it in two parts. So we've set out the criteria as we've set out in the paper, and we were looking yesterday to get public involvement and staff involvement in weighting those criteria, determining the relevant importance of them when it comes to selecting the site. The second part, which is then at the end of June, will involve the same people, the same group of people, scoring those the different sites, the specific sites, to determine with that weighting what the view is on the suitability of each of those sites. So yesterday was a first for us as a health board, and not, I guess, the normal way of health boards and other public sector organisations developing these sorts of plans. As we've said previously, we were seeking majority public involvement in that, which I guess is in particular the unusual aspect of it. So it's somewhat a step into the unknown. Pleased to say that we overcame any technical issues that could have been presented through running that through a Zoom call, and we had some very good discussion and good debate around them. Altogether we had just over 70 attendees throughout the workshop, and of those 43 people scored the weighting. We intentionally didn't have everyone scoring because a number were either supporting the process or felt they weren't in it, they shouldn't vote on that, or shouldn't score the criteria. And within that, then the split of those scoring was 54% public and 46% staff. So we achieved what we wanted to from that point of view. There's more work for us to do in ensuring we get the right representation for the June workshop. We did get good public representation, but we probably want to go further than that again, actually, when it comes to the June workshop. And one of the reflections, I guess, is some of the challenges of getting members of the public to be able to meet the dates and attend these sessions. But it was a very good discussion, and it was a balanced representation across our population, as much as we were able to achieve that. So I was pleased with how the workshop went, and it was certainly a good discussion and sets us up for the second workshop at the end of June.
Thanks, Lee. That's really helpful. If I could bring in Maynard, then Anna.
Thanks, Chair. Hi, Lee. It's a question in relation to the timing of things. The paper makes the point that obviously we've got no capital to commit until we get ministerial endorsement. However, we are progressing with the identification of the land. I'm just wondering whether or not we are going to be in a position to commit to the land before we have the ministerial endorsement.
So if I take the programme as a whole, first of all, for the programme as a whole, there's no doubt we're going to need Welsh Government capital support to progress the programme, and therefore, to some extent, where we get to in those discussions with Welsh Government decisions over the next few months will determine the speed at which we're able to progress those plans. There are aspects of the plan that we could potentially progress in whilst we wait any of those decisions if there is a delay. So particularly the community infrastructure plans, there are some aspects there that could be manageable either through some discretionary capital for at least the planning bit of it, not the builds, or from our partnership capital funds, and of course we've got cross hands on the agenda later today as an example of that. So potentially some of those could be progressed, albeit we would have to probably limit the speed of those developments to fit it within the resource we've got available. The major schemes like the new hospital, Glangwili, Withybush repurposing, and the refurbishments of Prince Philip and Bronglais will require that support from Welsh Government before we're able to progress them in any significant way. I think it would be unlikely we would be able to make any firm commitments to the land without that certainty that there was going to progress, and we would want Welsh Government support for that in any case. So there's I guess discussions to progress through the IIB and beyond on how we might want to handle that over the coming months.
Thanks.
Thanks, Lee. I'm going to bring in Anna, and there's also a question in the question bar from Hashim. How are you going to share the scoring exercise with staff and public and ensure as many staff views are considered when it comes to site selection? If you could take both those questions. Anna.
Thanks, Chair. Lee, on the technical criteria that you've asked us to endorse today, I'm just thinking about the conversation that's come up in various items already this afternoon around health inequalities. And I'm wondering where within that set of 7 criteria you would see health inequalities being reflected, maybe one, maybe more, and whether that is strongly enough represented in the set of criteria that we have.
Yes, so there's obviously this is predominantly about the technical site appraisal, so the suitability of the individual sites for the construction of a major hospital and so on. It's less about fulfilling the totality of the ambitions of the programme and the strategy, which obviously incorporates that. There are elements within the criteria that would reflect that, so particularly around I guess transport and access for the public will be important, and then some broader links around the impact on environment and ecology and active travel and other factors like that, so that there are elements and aspects that will reflect some of those components, but we're predominantly focused on that question of the suitability of the site for the hospital. So I think it's probably a question for us to consider, Anna, as to how we might reflect that in some of the other pieces of work that we're doing, so the clinical appraisal work and others. So I think I'll probably reflect on that question a bit further and consider how we might want to bring that into those for the subsequent work.
I think that would be really helpful, because I looked at those others and thought, well, where else? I thought perhaps that might be a response. And I thought, well, where else might that crop up? And I'm not sure that there's enough of a home for that yet. So it would be great if you could reflect on that and think about how we perhaps might just strengthen that a bit, given the significance of the issue that we're all very appreciative of. Thanks, Lee.
No problem. Thank you.
Thanks, Anna. Lee, do you want to address Hashem's question? Then I'll bring in Ewan.
Yes, absolutely. So we've the communication has gone out this week to staff, and what we will certainly make the results of the scoring exercise publicly available and communicate that within our workforce as well. So that will be communicated out in due course ahead of the second workshop, and then the results from the second workshop will be available in the same way. What we have asked through the communication this week is we've given people the opportunity to provide direct feedback on the implications of the new hospital site in respect of individual services, and where that might have an impact on either the potential for new services or the provision of current services. So we're more than happy and actively encouraging people to give their input into that. The other avenue for that is the work that Lisa and team are doing on the workforce appraisal. So we're keen to involve staff groups and staff more generally in getting feedback on the implications of that through that workforce appraisal process.
Thanks, Lee. And Becca, bring in Ewan.
Thanks, Chair. No, just to say thanks, Lee. I know the work you, Paul, and the team have been leading on this has been absolutely fantastic in terms of, as you say, it's a real game changer for Hywel Dda in terms of the depth and the public engagement which we're undertaking to actually make sure that we kind of transparent and open in terms of the 4 kind of shortlisted sites, and the engagement, as you say, is 52% to 48, which I think is great. I think perhaps when we see the depth of feeling around some of the proposals, as we've seen with Withybush and the public kind of interaction there, let's call it that, I think perhaps there is a role, I know it's noted in the report, but for some kind of further communications. I know Alwen and the team are trying to kind of make sure that that information is fed, but I think there is perhaps more we should do, because obviously the information around the public engagement within this decision process and the consultation of the shortlisting and the kind of technical appraisal, I don't think that's obviously getting through in terms of to those kind of people who are very active around as we see with the protests at Withybush. So I think perhaps there's more to do in terms of communications. I note within the report, there's some great ideas around doing FAQs, developing a video with young people, and engaging with individuals and groups who have expressed an interest in the strategy. I think what we need to do is to get to those wider population who haven't expressed an interest in the strategy as yet, because they're the silent majority who will kind of often hold sway in terms of some of those wider discussions across our communities. So perhaps it might be worth not just engaging with those who come to us as Hywel saying, well, I don't agree, or I would like to see this. There's masses of networks out there, which, I know with the day job hat on here in Pembrokeshire, but also in Carmarthenshire and Ceredigion, who would be very keen if they were approached to engage. So I think it might be perhaps, let's not wait for the communities to come to us, and often it's with a negative and a kind of a challenge. Let's perhaps be a little bit more proactive and shift our focus and go out to those established networks that are already there. I mean, in Pembrokeshire, you've got a network of 74 community halls and venues who meet on a quarterly basis. You've got a network of all these other sports groups and things like that. They will all be using this potential new facility. And I think let's think outside the box slightly in terms of our comms and not wait for them to come to us. Let's really go to them, as you've already done with the technical group, which is great, but I think we can do more.
Yeah, and I agree with that, and I think there's an opportunity for us to as this progresses now, to really reach out and engage with our communities in that discussion about what they want out of the strategy as a whole, not just the new hospital, which obviously gathers quite a lot of attention. But I completely agree with your point, and Alwena and I are going to be working on how we develop that comms and engagement plan over the coming weeks, and the intention is, and the spirit of this is for us to develop these plans in partnership with our communities. So we'll be looking for every opportunity to do that, certainly.
Thanks, Lee. And I think you've got a willing audience, and certainly I and others who work in the community and third sector will be more than happy to share those networks and bring those to you and Alwena to kind of disperse that communication as wide as we can.
Thank you.
Thanks, Ewan, and really welcome if you could feed in the details of the groups that you, with your experience in the communities, think that we should engage with. I visited Withybush Hospital the week before last, all the mental health facilities and radiology, and most of the conversation was really explaining and listening to staff about where we were in this process. So there will be question and answer sessions with our staff as well, because currently most of the information is through the media, which isn't as up to date or as in depth as that we have. But all colleagues, please feed in to Lee and Alwena the groups that you think we should engage with. That would be very helpful. And we have been precluded from doing that up until because of the PERDA through the local elections. But now is the time. So thank you. I'm going to bring in Paul.
Thanks, Chair. In relation to the technical appraisal, and the proposed criteria, item 7 under the criteria, the transport, patients and public, I appreciate there's a separate workforce appraisal, but could you perhaps share your thinking as to why staff and staff recruitment doesn't feature in that as part of that criteria?
Yeah, thank you, Paul. So so you're right. So the workforce appraisal group is looking at the recruitment and retention aspect of that, and that obviously relates then to proximity of workforce to where the new hospital might be. Predominantly, we wanted to just be clear that this work stream was then about how the public would access the facility, or be recognising that actually public and staff will access it in the same way, so the transport implications are broadly the same. So in truth, I'm not sure there's going to be much of a distinction there, even though we've set out that it's patients and public. If that was more to kind of get that focus on how individuals perhaps who have less personal access to vehicles or have poor public transport around them might be able to access the site. So but ultimately it will not be that different to the staff appraisal on that aspect.
Okay, Paul.
Yeah, okay. I think it perhaps depends on what the outcome of the workforce appraisal is and how that feeds into this process as well.
Yeah, yeah. Lee, in relation to the weighting in the technical group on the criteria, is that something the board would be endorsing, or is that something that would be adopted without board endorsement?
So we would want you to endorse that retrospectively, but obviously we haven't got another board now between now and the end of June, so it might be that we can take that through at least board seminar for a discussion, but I'd take your advice, Chair or Joe, on perhaps if there's another way of doing that between now and June, when the second workshop will be, or whether we do it retrospectively.
Okay, thanks. We'll discuss it with Joe. I know we have a board meeting on the 9th of June to sign off the accounts, but we can take that offline. I prefer not to do it retrospectively if possible, so we'll discuss that. Are there any other questions in relation to the work and the report? Okay, thank you, Lee, and all the team. It's an incredibly complex process. And as you quite rightly say, it's about the transformation of the whole health system for West Wales. It's not just about a new hospital, it's all the primary and community care. And although we've sent our business case to the government, we are actually, in competition with other health boards to be awarded this investment in West Wales. And so it's not a done deal by any means, but thank you for all the work that you're all doing to enable us to have the best chance that we have to get this 1.3 billion investment into West Wales. So diolch yn fawr. Colleagues, I'm going to give a 10-minute break if I may, and we will resume at 2:00. In fact, it's going to be 9 minutes, 2:05. Thank you. Diolch.
We are ready to go, Chair, but you're on mute.
Lovely, thank you, Judith. Just checking we were live. Many thanks. If we could then go to the next item on the agenda, which is over to you, Lee, please, which is the continuous engagement plan.
Yes, thank you, Chair. So, as we've noted in the previous discussions and in our strategy, we have a genuine ambition as an organisation to work together with our staff, patients and carers. And as we say, as the paper states, what we're trying to do here is make a shift from engagement being a reactive methodology and approach in response to what is normally the case in response to proposed service changes, to being much more proactive and ongoing and continuous, and to work with our public and stakeholders as genuine partners in the design and delivery of the health service and system. So the simple philosophy, I guess, behind the ethos of this approach is that if we're going to deliver outcomes that matter to people, then we have to start by listening. So the plan we've got here today is to in terms of set of the first set of actions we'll be taking to progress that approach. It's not intended to be comprehensive or complete or definitive in that sense, because we're really embarking on a journey here and a learning process as we seek to take those steps in that direction. And as the paper notes, it's intended to therefore be a live document which we will update, and it will evolve as we do that. It does propose a number of specific actions, such as the establishment of a public, patient and staff engagement group. And the intention of that is that we can triangulate the different feedback, the different engagement methods that are going on in order to get a more comprehensive view. And then, as noted, establishment of a Children and Young Persons Advisory Forum, so we can get children and young people's voice quite strongly into the way in which we some more experimental ideas within it, and the point of that is just to test new engagement methods, which, as I said, we will learn from as we go through. So more than that, I guess what we're trying to do is prompt new ideas for engagement and encourage and support a culture of continuous engagement into the way in which we deliver our services. So rather than engagement being delivered by an engagement team within the organisation, it's reflected in the way we do business in every part of the organisation. So just finally, Chair, on that point, what I would say is, as I've noted, this is going to develop and progress, and what I would be really keen to do is welcome input and contribution from the whole board. I have all the board members in trying to shape that and take that work forward, and I know a number of have been involved in different aspects of this, and certainly we would want to encourage that and look to do that over the coming months. So I'll pause there for questions and comments, Chair. Thank you.
Many thanks, Lee. I'm going to bring in a few people, but first, John.
Thank you very much, Chair. And Lee, thank you very much for the paper. You actually addressed some of the points that I wanted to make. I'm sure we all as board members would agree that if we are to be an effective organisation, we must see things through the lens of the public, our patients, and also of our staff. And I applaud you for this continuous engagement plan. I think it shows a level of our maturity as an organisation that, as you rightly said, this becomes our culture. It becomes our habit to engage, that we do that out of habit and we don't think in any different way. So I guess my question would be to just encourage you to ensure that, whilst I recognise you're talking about the 3 stages of life, and we've got plans associated with that, that the plan doesn't just look at issues around clinical change, but it's about the whole organisation, and that we do include schools, universities, education partners, and rightly the report does talk about hard to reach groups. That's noted on page 3. A little bit more detail around that would be helpful because that's not easy. But other than that, I'm pleased to see it, and I'm pleased to see the ambition that it's got within the strategy. Thank you very much.
Yeah. Thank you, John. Just to respond on aspects of that. So one of the key things I think for us to achieve in this is that point about how we do it in partnership with multi-agencies. So the point around education, local authorities, more generally the police force, universities, as you've mentioned. There's a bit of practical working for us to consider on that, and how do we actually do that? And I guess the establishment of the Children and Young Persons Advisory Group is a way of us doing that. And what we're also looking to do is align what we're doing with the work that's being done on engagement through the West Wales partnership, so that we're not asking similar people similar questions repeatedly, that we're trying to coordinate these activities across public sector organisations and then benefiting from the feedback that we get through different routes, if you like, because people see all of these things as single entities or whole things that affect their lives, as opposed to obviously being separated into those constituent parts. So certainly agree with your point there, John, and there's some details and specifics for us to work through as to how we're going to do that, but that is certainly the intention.
Thank you, John, and thank you, Lee. I'm going to bring in Dydd and then Sam.
Thank you, and it's diolch, Lee. It's really in addition to John's question, obviously, as you will know, I really welcome the involvement of children and young people, and it is key for us to think for the future of those individuals. Just really thinking about, though, the marginalised and the seldom heard children and young people. What actual practical plans have you got to actually really engage and listen to those children and young people that may not traditionally get involved in the type of work or the types of groups that you're indicating?
Yeah, I think that is the key question, Dydd, actually, because and that is a challenge fundamentally to all engagement, is that generally speaking it can suit some groups of people much better than others. So I think it probably goes back to Iwan's point previously, which is us not having a passive approach to this, where we ask people to fill in surveys or whatever that might be, participate in events, but actually we go to those communities, we go to those groups of people, and we go to their representatives as well, and have those open discussions. So part of the thinking here is not going to have a discussion about a topic, but actually just going to listen to some of these groups. So there's the specifics of that we kind of need to work through as to who and where and when and so on, but actually that's the philosophy that we're trying to develop here, is that as a engagement function corporately, and obviously then repeating across individual services, we'll be looking to reach out to groups to have that just open conversation, no agenda, no particular topic to talk about, just listen to their experiences, and that will help us then get a sense of their perspectives of what matters, and shape our responses to that accordingly. So I think just to address your questions directly, I think this, what we're doing, is the first step in that process. I think over the next months we'll get into the details of exactly how and when and who we're going to take that forward with. Thank you.
Thank you, Lee. And I'm going to bring in Sam.
Many thanks, Chair. Lee, really welcome the plan. The CHC sees continuous engagement as fundamental looking to the future, and we really look forward to working with the Health Board on this. My question partly relates to the previous discussions before the break. So recognising that this is a high-level plan, one of the issues that seems to run through much of the public concern about proposed changes. They feel worried about unscheduled care. They're worried that changes might distance them further from the help they need. Essentially, the question of will you be able to get to me in time? Will I be treated in time? And what we know is that some of those concerns involve genuine difficult questions and challenges around geography, and some are based on misconceptions which might seem basic if you live and breathe the clinical logistics of unscheduled care, but which are entirely understandable if you don't. So continuous engagement feels like a perfect home for starting and maintaining that kind of complex discussion. And therefore, can we have some assurance that this will be part of the plans looking ahead?
Yeah, absolutely, Sam. So, and obviously the intention here is that the two things we talked about today and subsequent items on the agenda are not separate parallel pieces of work, if you like. They contribute and complement each other. So I think you're absolutely right that some of the anxieties around the proposals are genuine concerns and fears for access to some services in particular. That's come through a lot of the discussions we've had, and a way of addressing that, as you say, is to engage in a conversation, particularly direct conversations with clinical leaders and so on as well, so we can address some of those points directly. So the two are entwined together, absolutely, and I guess it goes back to Ewan's point earlier, which is particularly around the strategy and the new hospital and other developments like that. It's a case of us engaging with specific communities with specific concerns to understand those, hopefully reassure them as much as that's possible, but also where they have ideas or priorities for us to consider, that we can hear all of those and incorporate them into our plans as we develop them. So yeah, I certainly see them as both contributing to each other in that way.
Thank you.
Thank you, Lee. Are there any, and Sam, any other questions?
Maynard and Anna.
Thank
please.
you. Thanks, Judith. Maynard.
Hi, thanks, Lee. Again, great paper. Really positive to see the plans for continuous engagement. Again, I'm speaking on behalf of a particular group of people that I don't see mentioned there, and that's older people. They are a major consumer of our services and our partner services. Whilst there's reference to the stakeholder reference group there, I've checked the terms of reference of the group. There are no specific older groups, even on our stakeholder reference group. So I'm just looking for assurance that that group will not be neglected in favour of the younger people.
Yeah, good question, Mike Maynard. So it's always challenging, isn't it? Because we've obviously got a complex, diverse population, and there's a danger, isn't there, in trying to carve it up in too many different ways, and then not properly representing certain groups and so on. But the plan itself, as you can see, is obviously set up along those life cycles. So certainly a strong focus and an intended strong focus on older age groups. The stakeholder reference group, whilst it doesn't have a specific older person's representative, is actually well represented from older people in that sense. But one of the discussions we have been having is as I've said, we've set one of the early actions is to set up the Children and Young Persons Advisory Forum. And actually there's an argument for us to do something similar for older age groups, and then there could be something in the living well category as well. So we're giving that some thought as to what the appropriate way would be of setting groups up to ensure that we accurately reflect each of these different age ranges.
Thanks, Lee.
Thanks, Lee. Anna.
Thanks, Chair. Lee, I'd echo the positive comments around seeing this item today. It's very much welcome. I'm wondering, how we might strengthen it further, and thinking about, yes, of course, having mechanisms for people to engage with us is really important, and the plan covers that really well. But there's also something really important about the relationships we have with the public and the trust that the public have with us. So I'm wondering whether there is a gap in the plan as it's currently written, which reflects the importance of building trust with our communities, strengthening trust with our communities. And that might be directly, but it might also be indirectly, thinking about who are the honest brokers, who are the people in our communities that inspire and have the confidence of the public. And how might we also think about working to build our relationships with those key people and groups who can help us build that strong relationship with our communities.
Mm-hmm. Yeah, I think that's a really important reflection, Anna. So I guess the thinking here is that by engaging in the way we've set out, or beginning that journey of engaging in that way, that we will build trust through that process. I think you're right, though, that actually there are aspects we can do above and beyond that, particularly indirectly. Because trust is an issue for us from some groups, and I think we need to recognise that and try and respond accordingly. Yeah, I think probably there's a question there for us to think further on as to how we might do that through that honest broker or key influencers point that you mentioned. I think that's something for us to think further on. I agree, Anna.
Thanks, Anna, and thanks, Lee. So based on the suggestions and also the thanks of the members of the board, is the board happy to approve the continuous engagement plan for 2022-23? Many thanks. If I could briefly go back to the previous item, which was about the technical appraisal group and the technical criteria. We discussed about the weighting coming back and have later on and having a discussion about it, but we omitted to endorse the technical criteria for the technical appraisal as in the recommendation. So I'd be grateful if board can indicate that they're happy to endorse the technical criteria for the technical appraisal, and we will later consider the weighting of that. Thank you. That's lovely. Thank you very much. Apologies for that. And so the next item on the agenda then is hold on a second. I think it's the IMTP, I remember.
It is, Chair, yes, thank you.
Yeah, over to you.
Okay, thank you. So as a reminder, we brought the 3-year plan, or the draft 3-year plan, to board in March, which was approved and then subsequently submitted to Welsh Government. That plan set out in detail the actions we're taking as a health board to deliver on our strategic objectives, progressive strategic objectives, and respond to the pandemic and the recovery from that pandemic. Board members will recall that the primary reason that the plan was draft was due to the fact we were unable to provide sufficient assurance on a financially balanced plan over the 3-year period, which is a prerequisite for an IMTP to be approved. We've consequently been doing further work over the last couple of months and through this first quarter with the intention of providing an updated plan to the July board. The paper notes 4 key areas where that work has been progressing. We've been building on the work done on planned care recovery, and we'll be looking to bring an updated version of that as part of that plan. Work has continued on the 10-year workforce strategy, and that obviously also relates to our programme business case and strategy that we talked about earlier. Another crucial aspect which relates to all of this is obviously us seeking in the endorsement for that programme business case itself. And then finally, the point around the roadmap to financial sustainability, including in-year savings opportunities, which is obviously a significant challenge for us as a health board. So in the paper, it's recognised that the scale of savings and the scale of change we will need to see will necessitate a transformational shift in the way in which we deliver services. And the paper sets out an approach to that around the target operating model and the way in which we will review and transform our current models of care. So it's a fairly brief update, but I guess the other items to say is that given our pre-existing deficit, it was always recognised that an approval IMTP was going to require some Welsh Government transitional funding to get to that point, and therefore would need agreement with Welsh Government on that basis. With our current financial forecast, which is obviously presented later on the agenda, it is clear that it's going to be a significant challenge for us to get to that point and agree such an arrangement with Welsh Government. So at the moment, our anticipation is that it's unlikely at this stage we'll get to an approvable IMTP in July. What is more likely is that it'll be an annual plan from a financial point of view, set within a 3-year transformation and delivery plan, which will be very similar to what we've already set out, but obviously updated from the last few months. So that is, I guess, the main item to update the board on, Chair, but happy to take questions and comments, and I'm sure other exec team members will want to contribute to some of that as well.
Many thanks, Lee. We can open it for questions and comments, or any of the execs to come in. I think you must have explained it incredibly well. There we go. Is this Phil or Judith?
It's Phil. If there are questions, I suppose, perhaps I'll let Winston come in first, to be fair.
Absolutely. Thanks, Phil. Winston.
Hello, just checking, can you hear me clearly? Because sometimes my IT is off and on. So
Yes,
yeah, thanks for an update on this paper, and I presume, although Lee, you've talked about it, this is a whole exec team looking at this from the different angles of finance, performance, staffing and care as well. I think it's a really difficult thing to change a target operating model to a new one. I think, or your current operating model to a target one. And I think that does require a lot more thought and consideration and engagement of our clinical and operational teams, as well as, you know, your previous paper around engagement as well, because we actually need to check out what does that mean for, you know, our carers and stuff. I guess comment would be, I'm a little disappointed that we're not going to be able to submit even if it's a draft IMTP plan until July. But what I would want us to understand is what that financial gap is, because my sense is we have said that we're going to achieve a 25 million deficit this year. It's going to be more than that for this year. And my sense also is if it is going to be worse than that, then let's ensure that we, as much as possible, deliver to our performance targets and improving the quality of our care as well we deliver, I think, because if we try to achieve a financial balance, and I agree with the Health Board completely on this, we wouldn't get there and be able to sustain the quality of our services. So I would very much certainly support that we, at least as a board, have a draft plan that says we're going to achieve all of these things for performance quality, but this is the impact on our finances. That's my first point. I guess the second point is I think it's worthwhile if we can communicate to the Welsh Government about how difficult it's been in the pandemic to just suddenly turn off the tap of all the resources that we've committed towards immunisation, vaccination, staff working a combination of being at home and working in the offices as well, to suddenly get to a position where we're suddenly delivering a lot of savings. And this might just my comment on what's happening in health in general. We've suddenly gone from putting a lot of resources to supporting people and save care and staff to go into a savings piece, which I think is really hard for anybody to get their heads around. So I'm a bit long-winded about this, but it's something I really care about. I think we're right to signal now that we're not going to get a balanced TP, but at least get a plan that really assures ourselves around performance and quality. And that's coming from an iron within the finance interest.
Thank you, Winston. I think it's a great sign of maturity when the finance independent member focuses on quality and safety, and quality and safety focuses on finance. But thank you for your wise words there. I'm going to bring in Hugh.
Diolch, Cadeirydd, and thanks, Winston, for the comments there and Lee for the introduction as well. I think you asked a very specific question in terms of where we are now with our financial gap, and I'll come on to that in more detail when we go through item 4.6, given we are in the year that we're talking about now. And at the moment, we remain in a position where I can't say we've got assurance that we will get any better than 42 million. And I said that when I presented the financial plan back in the March board meeting, and that remains the position. And there are some other challenges which I'll allude to later. The work on the target operating model, as Lee said, is absolutely crucial, because when you're dealing with a challenge of that scale, that challenge in and of itself isn't a financial challenge. It is born from service sustainability challenges and demand pressures that we're seeing across the service. So a change to the target operating model and the way we provide services is absolutely important. So this isn't in and of itself a financial challenge. It is a much broader structural issue that we're dealing with, and that is proving difficult to work through in terms of the implications on services, on quality and safety in particular, on the workforce demands that we'll see. But that is indeed the work that the exec team are all collectively working through at the moment.
Thanks, Hugh. Are there any other questions or comments before I bring in Phil? Okay, Phil.
Thanks, Chair. So Lee and Hugh have described it really well, and agree with Winston that whilst we have a real ambition to have an approvable IMTP, we do have to have a balanced approach, and it very much is a whole exec team effort on this to make sure that we really do have that balance. We've got some really big challenges around the finances and in our operations and the way the system's working at the moment. Not all of that will be solved through money, actually. Some of it will be just challenges of changing service and service transformation and bringing the public with us. I think we've got quite a bit of work to do, I would say, in terms of development of our plan. There will be an opportunity in the board development session in June for us to have a re-look at this and to see where we've got to before we submit the plan to board in July, which I think is helpful for us to have a stock take at that point as board members. And we'll pick up the detail around the finances, as Hugh says, in the finance update a bit later.
Thank you, Phil. So on the basis of the discussions and the points, are the board happy to accept the recommendation? Many thanks. If we now go on to our annual recovery plan. And again, I think that's you, Phil.
Yeah. So we described our annual plan last year as an annual recovery plan, given the context was that we were still very much in the COVID pandemic, and we, as is described in the paper, it was the first full year of us having our 6 strategic objectives in place and our series of planning objectives in place. So it was a new system of working for us, describing our annual plan through that lens, and we felt actually that this is quite a novel approach, and that the planning objectives give a real insight into the executive objectives, the individual executive objectives, because each planning objective, as we know, has an executive oversight. Through the year, of course, our assurance processes have been through each of the committees, with each of the planning objectives being attached to one of the subcommittees for oversight. And in the most part, I think that's worked well. We are just reviewing in some cases where planning objectives might not have had quite such an area in those subcommittees as others. So that's something we're working on and looking at for next year. You'll see that some of the planning objectives are closed. All of them are re-looked at in light of the new plan that we are looking to produce in July this year. The other part of this paper that you'll see is a personal reflection from each of the executives about the planning objectives that they were responsible for. The reason that we felt that was important, in slightly separate from the assurance processes that we've got through the subcommittees, we felt, is that this is the first, as I said, the first full year of these planning objectives being in operation, and we thought it was really important information for the board to see the executive's reflection on the planning objectives and the processes, both showing where things have worked well and where those challenges are, and perhaps useful to see them as a total. So when you look at them, they are written by different authors, and they look like they've been written by different authors because they have been. And I suppose they're hopefully they're taken in that spirit. But it's a closure report on the first year of the strategic objectives and the planning objectives being in operation, and happy to take any questions.
Thank you, Phil. Open to questions or comments. Okay. Question, John. Sorry, Paul.
Thank you, Chair. Yeah, I don't know whether it was just me, but I found Appendix 2 quite difficult to follow, and I thought that it was perhaps incomplete, and that's not all of the plan and objectives which were allocated to a particular executive have been commented upon by that particular executive. I don't know whether it's the intention to sort of take these to the respective committees now for final sort of confirmation that they've been closed off. If that is the intention, then maybe perhaps these responses could just be revisited before they appear before those committees, for the exec team to just sort of reflect on the answers which were given there, and to make sure that they are actually tailored to the information that each committee might need in order to gain assurance that the plan and objectives could be signed off from last year.
Yeah, I'll pick that up with Joe and Lee, because I mean the programme of assurance on a routine basis, there are updates going through those committees, but I suppose your point is a separate level of assurance about the closure of them from last year. So I'll pick that up with Joe and Lee.
It wasn't actually the intention, Paul, to take them back through the committees, as Phil's rightly said. That would be through the updates against each plan objective. I think the point that you read earlier, Phil, is a really important one, because I think we do need to do a piece of work in terms of all the planning objectives that are aligned to the committees to make sure that they are all going there and that they're looking at each planning objective rather than trying to retrofit some, which I think is what's happening to some of the committees. But happy to take that, Paul, and have a look and see if we can tie both things together to give assurance back to the committees on behalf of the board. I can work with Lee on that.
Yeah, I didn't want to sort of go through them line by line, as it were, but just to sort of pick on one example, maybe in the Director of Operations, there's a reference to the Bronglite strategy, and then there's no narrative in relation to that particular objective in the comments underneath, and the Director of Workforce comments. It's more of a sort of discursive summary, really, of the position rather than particular reference to any particular objective. So those are the sort of issues that I think sort of made it quite difficult to follow, really. Certainly for me, anyway. Perhaps it's just me.
But and I think to be fair to individual directors, it was the request was for a personal reflection. So, and whilst we did put some structure around it, it meant that the request was interpreted in different ways. You know, so I know the Director of Workforce probably followed the request to the letter, whereas others probably interpret it more broadly and put more detail in actually. So yeah, I think we can learn from that in terms of when we request this kind of personal reflection. I suppose we could have anticipated that there might have been a sort of broad church of interpretation of the request. But we'll work on your point about the connection with the subcommittees and how we'll just reflect on how we link that to them in terms of closure of the planning objectives for last year.
Thanks.
Thank you, Paul. On a general point, I think it's been an excellent exercise, the whole issue of strategic objectives and planning objectives linked to executives, an excellent exercise of discipline and us being able to follow what we are promising to do and whether it's delivered or not. But taking on board the fact that this will go now in a sort of a more disciplined format to the committees. Is everybody happy to accept the recommendation? Many thanks. The next item on the agenda is the operational update, and I think that's going to be Keith and Jill.
Yes, thank you very much, Chair, and I will introduce this item and ask Keith to come in really to update on some specific points. But this is the first report that we've provided in this format, and usually at this juncture the board receives a report from the Chief Executive in terms of our response to COVID in particular. And as we've discussed this morning, we're moving back into that position of focusing more around our individual priorities, our clinical priorities, and the Health Board strategy and delivery plan, and also responding to some of the Welsh Government requirements in terms of quality and delivery as well. So what this paper does set out is the infrastructure that we've put behind this in terms of our business planning arrangements, supported by operational delivery and a focus on quality and safety. And it's really important that we have the infrastructure right. What I think this report also indicates is that we're still looking at that balance between the elements of COVID that are within our organisation and the challenges that we face now from delivering business as usual. And the report also sets out the complexity, I think, of what we're looking at. And it's a very comprehensive report, focusing on representation from the members of our whole system. So there's an update provided in terms of that area. But, you know, this morning, if I look at the challenges we face in our organisation, all 4 of our hospitals are surged to a risk score of red level, risk red on level 4, red 20. So really facing a challenging position in terms of delivering our organisational priorities while still facing the challenge of the impact of demand for patients within our system. So we don't propose to go through all the detail of the report. We will welcome not only feedback on the format of the report and how meaningful that has been to board members, but also happy to pick up questions on specific areas that we've reported today. But I just wanted to ask Keith to come in on 2 specific areas in particular, and others, if board members wish to, but particularly on some of the challenges we faced over recent weeks in terms of ambulance delays and handover, and also some of the aspects around our planned care recovery. So if I can bring Keith in at this stage, and then we'll be very happy to take questions from board members.
Thank you, Jill. Keith.
Thank you, Jill, and thank you, Chair. Yes, echo all of Jill's comments there in terms of the breadth that the report covers. Yeah, just two areas I'd like to highlight. The first, as Jill has indicated, in terms of our ambulance handover performance and the pressures that we've been seeing at the front door. We've made some reference to that already through the meeting this afternoon, and I'm sure we're all very cognizant of some very distressing stories that some members of our population and our patients and their families have experienced over recent weeks and months, given the level of the pressures that we've been experiencing. Aside from our broader transforming urgent and emergency care programme, which, Chair, I know you've already mentioned in the meeting. I just wanted to draw colleagues' attention to a specific piece of work we've also enabled over recent weeks, jointly with the Welsh Ambulance Service Trust, where we've established an operational delivery group that is specifically focused at measures to try and improve handover performance. The work of that group is referenced in the paper. It's broadly focused on 2 or 3 sort of thematic areas, really. One is to try and reduce those levels of conveyance and demand that's coming into the system by enabling our paramedic colleagues maybe to make better informed judgments and decisions about the clinical assessment and judgment they make around patients. So there's a number of aspects to that work, particularly around affording paramedic teams more direct access and communication access to our same-day emergency care units in each of our sites. And we've started that process in Withybush over the last couple of weeks, and we're steadily now rolling that out to our other units. And early indications suggest that will have some positive benefit in allowing maybe better decisions to be made about the transit of individual patients, and certainly transit of those patients away from our ED environments. That work is also focused on enabling our paramedic teams to maybe have a better level of communication with our social care teams and the pre-existing packages in place for patients. So again, understanding the context of patients and informing decisions that can be made at the point in time that patients are assessed within the community setting. And then thirdly, building on some of the mechanisms that we already have in place. We know that within the Withybush system, we've got the blue team there, and there is an effective line of communication between the in-hospital team and our paramedics in the county. Building on the PTAS work, the work where we've got some of our GPs reviewing patients on the ambulance demand log and understanding whether we can offer some clinical advice to that. We've now agreed with WAS to progress a pilot initially within our Carmarthenshire area, but within a view to expansion of it, where they're looking to dedicate some advanced paramedic practitioners to work in our system, again, to provide that upfront clinical advice to the crews on the ground, and hopefully then avert the transit of some patients to our hospital system. That initiative has been piloted in the Swansea Bay area in recent weeks and months and shown some positive results. So we're very keen then to roll that out now over the next couple of weeks in our patch to see whether we can get a benefit from that. There are some other elements to that work as well, which I won't go through, but which are referenced in the paper, but I just wanted to highlight that from our ambulance handover focus, because I think that's an important part of what we're trying to do. And then the paper also describes in summary form a stage of progress, if you like, in terms of our planned care recovery, and it references where we're at with some of our infrastructure developments around the Modeler unit and the Yaman Valley development. It's pleasing to see now that we've got our elective operating working again across 4 sites. And albeit that they're not at the levels that we would have enjoyed in the pre-pandemic period, but we're steadily trying to increase those volumes, and there is some good progress being made on that front. And then the work that the planned care team are doing specifically to try and get an absolute fix, if you like, now on our trajectories for increasing activity through the rest of the year, and how that then will play against our forecast levels of demand as we go through the remainder of the year, and then give us a much better understanding of where we might lie against those recently announced ministerial priorities for planned care, and particularly those key staging points in terms of outpatient waiting times by December and the overall pathway waits by March. So I'll pause there and happily take any questions colleagues would wish to raise.
Thanks, Keith, for your comprehensive summary, and thank you, Jill. Jelith.
Thank you. I've got 2 questions, if I may, in regards community pharmacies, Jill, and also WAST colleagues in regards our community first responders and the use of volunteers, because when we think about choosing well or intervening earlier for our population, those 2 facility or two provisions are really key in actually assisting our communities. So are community responders involved within your summit? That's one. But in regards to community pharmacies, in the last few weeks, we've seen a real downturn in community pharmacy provision in my local area in particular, because of recruitment and retention issues. And community pharmacies, as we know, they are part of the process that we can choose, that we can encourage our public to choose well and choose wisely. So are they involved within our discussions? Thank you.
Thank you. I mean, I'll pick up the first one then around community pharmacies. I may ask Keith to comment on the volunteers as part of the first responders team. We have seen, and we continue to report as part of our operational update, the issues around primary care, Dydd. And yesterday we had two community pharmacies who were at red level and two at black. And where we've got community pharmacies at level black, that does mean there are frequent half-day closures as a consequence of some of the issues that you raise around staffing and sickness. Now, that we felt was an underreported position because we've seen a more significant level of half-day closures from community pharmacies right across Hywel Dda. So we are looking at the reporting tool and reminding community pharmacies that we update that. Community pharmacies also undergoing contract reform. And as you say, there is a really important role that community pharmacies have in the delivery of alternative services outside of our hospitals. So it's something we're working with CPW and our community pharmacies to address. But if you have got specific problems and, you know, the community, members of the community do want to contact us about any concerns, those are things that we can pick up with the individual providers in terms of the challenges that they're facing. Where there are repeated closures and it's not reported in the way that it should, it potentially could take community pharmacies into a breach of their contract. So again, we would want to try to avoid that and work with community pharmacies in terms of addressing some of the challenges, but making sure that patients can properly access their prescriptions and the alternative services that community pharmacy does provide. So thank you for raising that. Keith may come in now.
Yeah. Thanks, Jim, and thanks, Dydd. I must confess, I've not received many concerns in respect of coverage around our first responders. We know that our WAS colleagues, of course, draw upon many avenues to supplement the capacity, particularly at those times of particular pressure. But what I can commit to do for you, Dydd, is to pick that up with our regional head of service in Hywel Dda. We've got a very good developing a relationship with that individual who's recently appointed, and I can maybe delve into that a bit, and then provide you with a report back to really bring that issue alive, if that's okay.
Thanks very much. If I can bring in Judith.
Yeah, thank you. Jill, you asked at the beginning about sort of feedback on the report, and I think it's quite a hard report to feedback on because inevitably with all this information you delve in and potentially could ask an awful lot of questions, and also you compare with other reports that are there like performance reports, and then you can see maybe variations because of timing. So I think maybe in terms of thought about what it's about may be helpful. And because I've made that comment, I do have very specific questions, so you'll have to forgive me. I think the first one's probably, well, maybe both for you, Keith, actually. On page 6, you talk about the transforming urgency and emergency care piece of work. I'm just trying to understand the thinking behind needing to appoint someone specifically to oversee that. And okay, the money's come from Welsh Government, but I guess linked to that would be, is there a risk that we appoint internally and then we leave a gap somewhere else? Because we are doing that. So that was one. And the other one for clarity, on page 7 under the autism spectrum disorder, I just want to confirm the increase in referrals. My understanding that was for children, but it's not explicit here. So I wonder if you could confirm if that increase in referrals is adults and children, or solely children? Thank you.
Sorry, Jill. Sorry, Jill, you jump in first.
Okay, just in terms of the format, I think that's really helpful feedback. And one of the things that we may consider in future reports, rather than report on everything, is to perhaps pick particular themes that may be relevant on a different board meeting that we can put a little bit more depth around. So that's certainly something we will look at. On the issue of the appointment process for individuals to lead and help us programme manage this really ambitious programme, Welsh Government are quite specific actually in terms of what they expect, and along with the money they have set out for us what they would expect organisations to put in to enable us to deliver such an ambitious programme, and that does come along with relevant clinical and managerial support at quite a high level to enable us to ensure that we've got the strength behind this and the focus on this, not relying on people just in busy day jobs, but we've got a dedicated focus on this that will draw that support from people in busy jobs to help to drive this forward. We will be looking at our appointment process, but there are clearly individuals who are within the organisation now who are delivering aspects of this programme. So the expectation is that we would certainly be starting to look at the internal opportunities that there will be for individuals who may be already part of that. We will clearly have to have the appropriate process in terms of any recruitment, but you're absolutely right, when these new opportunities come along, it can potentially mean that there is a gap then created in the system elsewhere. So that's something we will have to focus on depending on the outcome of that process. I'll perhaps hand over to Keith then for the issue around the autism service.
Yeah, thank you, Jill. Yes, Judith, my appreciation is that the increase is related to our paediatric group. I can take that back and have a deeper conversation with the mental health team just to establish whether there's any element of that that's transferring through to the adult group as well. But that reference is geared to the paediatric group, certainly.
Great, thank you.
Thank you. If I could bring in Maynard, please.
Thanks, Chair. I'd echo Julie's concerns about Welsh Office money creating gaps elsewhere as we try and cover other things. But a couple of specific things. Keith, you mentioned about trying to reduce the number of people actually being transported to hospital. But in your report, you mentioned that on page 4, there's an increase of referrals into the unscheduled care system from healthcare professionals and an increase in volume in the over 75s cohort. Particularly interested in the referrals from the healthcare professionals. Just wondering if you can give us some more background on that, please.
Yeah, thank you, Maynard. And it is an interesting element of the way the data is playing out right now. So we are certainly seeing reduced, notwithstanding all those pressures that we're describing, with ambulance arrivals into hospital are certainly reducing. Yeah, but within those patients that are presenting, and they are presenting in increased numbers, we are certainly again seeing an increase in presentations via a healthcare professional, predominantly through primary care. Yeah, Sean may want to give a perspective on this. Our considered thought on that point, Maynard, and I think that's the best way to describe it at this point. This is in part a legacy of the pandemic and a reflection both of perceptions around reduced level of access during the pandemic period, but also then the impact on patients who, for one reason or another, have not accessed care to the volume that we might have expected during that pandemic period, and therefore the legacy on the impact on their condition and deconditioning, etc. So that's the considered thought as to the underlying reason for that. We have to recognise that and respond to it.
Thanks. You're on mute, David.
Thank you. If I could bring in Sean on the same point.
Yeah, certainly agree, Keith. I think there's a significant amount of unmet need out there in our communities, partly as a result, as you say, of patients delaying presenting because they didn't want to come and see their practitioner. I think across primary care, across all providers, there's an increase in presentation, probably around the mark of 25%, I think, on a daily basis. So I think it's not a surprise then that the impact of medical admissions, surgical admissions, and then onward referral for routine work is significantly greater than it has been pre-pandemic. So it's not a surprise.
Thanks, Sean. And that's in the context of our capacity. Sorry, Maynard, carry on.
Yeah, just one more question, if I may, Chair, and that relates to the mental health and learning disability section and the use of digital counselling. I was just wondering, have we got any feedback on how effective that is, and are we getting any feedback from our service users on that?
Jill, you happy for me to take that? Yeah. No, yes. So thank you, Maynard. Yes. So it's important for us to remember that the digital sort of counselling packages are generally geared to the lower intensity patients. Yeah, so in terms of their suitability and their appropriateness, so that they're less related, for example, to maybe some of our specialist psychological therapy waiting lists right now. There are two broad systems that are being used at the minute. One is termed Cyfarfod, and it's a particular package, and there's another one then which is more geared towards guided self-help for PTSD patients. The Cyfarfod system, which is a system that's been promoted and resourced by Welsh Government, was initially trialled in Powys and then rolled out to other health board areas. At this point, the data on outcomes is still probably best described as in its relative infancy, but I guess there's a sufficient level of considered thought around the impact of the service for it to have been rolled out across all health boards. Yeah, so I think there's more evidence to come on the benefit of that as we go forward. With regard to the other package I referenced, which it's described as spring training, but the spring program, but it's basically guided self-help for PTSD patients. The benefit of that model is it leads to fewer interactions and sessions than the sort of traditional clinic-based approach for cognitive behavioural therapy. The evidence on that from where it's been used elsewhere in the UK is stronger, if I'm honest, in that certainly for patients with low to moderate PTSD symptoms, the evidence is quite strong, the package is quite robust, and the research evidence there is pointing to some very good outcomes. So again, we need to build our own experience around that, of course, but the view is we've got to try these innovative approaches. And given the size of the task that befalls us, and it's incumbent upon us to try and a range of innovative approaches to try and get on top of the demand backlog that's there. So I'm sure over the period ahead we'll be in a position then maybe to share some more local data and reflection on the benefit of these packages, but certainly there's a strong commitment within the service to try these for the benefit of our population.
Thanks, Keith. Yeah, I think my main concern is that we are keeping an eye on it to make sure that they are effective, and we're getting outcome measures reported back from our service users. Thanks very much.
And just to clarify, particularly with that that first programme I mentioned, the Silver Cloud, because it is an all Wales initiative, if you like, there's a structure around that where we, along with other health boards, are reporting back in then and monitoring our progress. So.
Many thanks, Keith. I think I'm going to bring in Winston and then Paul.
Thank you, Chair. Thanks for the report. On page 5 of your report, you talk about the Transforming Emergency and Urgent Care programme, and you mentioned an initiative taking place at Witherbush General Hospital. The next point I'm going to make is not related to this paper, but it's related later on in the board pack, where we've got the month-one performance information, and in that month-one performance information, we look at the patient experience in the ED departments during April. And I know that Witherbush and Glangwilly are significantly less than Brognace or Prince Philip. My question really is, to what extent are we going to focus our transforming emergency and urgent care programme towards those emergency departments that aren't appear to be having the better patient experience?
Yeah, so thank you, Winston. Our programme is focused right across the health board, because one of the things we have to be very mindful is equity of opportunity for all our patients right across our health board area. Inevitably, though, we would then be expecting to see those benefits play through in those hospitals where perhaps the impact of that demand capacity imbalance reflects itself to the worst extent, and that tends to be Glangwilly and Withybush. So as I mentioned in my earlier answer, the initiative around Welsh Ambulance Service direct access and referral to our same-day emergency care unit, for example, we've started that in Withybush. And that's part of a reflection, I guess, of where we anticipate the need. We want to roll it out across the health board. We're doing that, but it's important to start it somewhere. That's just one example of how we're approaching that programme.
Just to follow up, I get that you're doing it across the health board, but I'm just thinking about it from the sort of patient experience point of view. Do you think we could get a bigger bang for our buck, if you like, or bigger impact if we did look at those areas where the patient experience doesn't appear to be as well as others? Just want to get your sense of that.
Yeah, I suppose the point I'd want to draw out is the fact that we're taking our approach across the health board area is not to the detriment of any one individual county or any one individual hospital location. If we think about our broader transforming urgent and emergency care programme, of course, we're taking that forward in partnership with our 3 local authority partner organisations as well. So necessarily then there's a focus locally within each part of our health board area. So I think it would be wrong for us to interpret that approach as prioritising one area over another. I think we're trying to take that equally across the piece.
Yeah, thank you. Thanks very much.
Thank you. Paul.
Thank you, Chair. Yeah, first of all, I'd just like to echo Judith's comment earlier about the format of the report. I think you look at the headings in this report, and probably everything in this report is probably aligned to one of the committees. And I think that the danger that we have then is that we turn this discussion into a bit of a mini committee meeting, where perhaps we haven't necessarily got the time to go into the issues in the same sort of depth as we may do in committees. So perhaps some reflection on that. And with that sort of entreaty, if you like, in mind, just a couple of questions that I'd perhaps like to pose. We obviously focus in the report on the length of stay and the challenges in being able to discharge patients, but is that not just one part of the issue, and are we doing everything that we possibly can to ensure that we have patients able to discharge as soon as possible once they've admitted, and indeed are we admitting patients appropriately? And then second question is on psychologists and the difficulty in recruiting. To what extent are we linking with universities, and particularly Swansea University and the undergraduates there, to try and attract people to the health board? And a final one, perhaps not for today, but maybe separate to the meeting, perhaps somebody could provide me with some information about the number of patients who are subject to DOLS liberty protection. What's the range of stay detention for those patients? Okay, thank you, Paul. So I'll go through those in order. So in terms of the first question you posed, in terms of how fit for purpose is our discharge pathway, essentially, and offering this comment as the Director of Secondary Care in terms of my direct responsibility for our hospital systems, it is inevitably the case that there is scope for improvement in the way in which we progress patients through all part of our system. Yeah. In fairness, that is part a reflection of the level of pressure on the system at the minute in terms of our staffing challenges, our reliance on locum staff, and inevitably the effectiveness and the efficiency of our systems and processes will not be as high as we would wish to see if we had a greater reliance on more substantive staff. It's for that reason, I guess, that our
transforming emergency care programme is very, whilst recognising the challenge of the discharge pathway in the back door. It's for that reason, I think, has been referenced earlier in the meeting, while we've got such a focus on frailty and the frailty matters approach within our programme, which is very much geared to maximising the opportunities available to our multidisciplinary team, because it's not the business of any one group here, to, on the one hand, as I've already indicated, reduce levels of conveyance into our system. In addition to that, then, making effective and sensible and sensitive decisions around admission or not at the point of presentation, but also then trying to minimise the length of stay that those patients experience, for risk of those patients with a longer length of stay, that adds to the problem and the size of the challenge we've got. So the focus around our integrated multidisciplinary teams working more closely together in a more coordinated fashion is all geared to ultimately providing more targeted care to our patients, particularly in that early period of their stay, such that we minimise the volume of patients who progress to longer lengths of stay. Yeah, so we're almost trying to reduce the supply of patients who become medically fit, and then try to address the problem that way. Does that answer your first question before I move on?
Yeah, I think it does, and it just sort of highlights, I guess, that because of the nature of this report, it's sort of focused on one issue as being the cause of the problem, as it were. Whereas it, as you've just highlighted, it's much more complicated than that, and it's a much more whole system issue rather than just one aspect of the system.
Okay, and then on to your second question around links with the university around psychologists. So it's probably just important bit of detail for us to understand here that the Swansea University undergraduate degree course would only benefit us in terms of the supply of assistant psychologists, and that's not really the area where we've got our recruitment challenge. We tend to be inundated with applications of graduates for assistant roles. So unfortunately at this point the university course does not provide training for clinical psychologists, where the crux of our challenge is. So and that's a more complex area. There's a very lengthy answer I could then give you in terms of, I'll follow through that, but I'm happy to pick that conversation up separately and maybe drop a note to explain that in a bit more detail. But the focus of our recruitment challenge is more on the clinical psychology side than it is would be the assistant practitioners.
And could I also bring in Lisa on that particular item as well, please?
Thank you. So as Keith has just explained, it is the following programme. I have had conversations with HEIW, with our head of psychology, and we have been able to secure some places for the organisation. So we will be beginning to develop a programme now for at least 4 practitioners to go on that programme every year. So we have been able to unblock part of the challenge of that programme.
And Lisa, is that the clinical psychologist programme, so they don't have to leave here and go off to Cardiff or Swansea?
It's a 1-day-a-week programme, I believe, in Cardiff, but it will be our staff that will be able to access 4 places on that programme moving forward.
Super,
So
many thanks.
Yeah, thank you.
Thank you. I'm going to bring in Phil.
Thanks, Chair. I was just going to make a sort of general comment, just reflecting on Judith and Paul's points.
Phil, sorry, Phil, before you do that, could I give my opinion on the format as well?
Oh, sure.
Okay.
Sorry.
Obviously, we're all, a group of us, but I actually liked the format of the report from the view of the public being able to see all that information in one place at a board, where they're unlikely to go to all the different individual committees. So totally respect my colleague's opinion. I just have a different one, that's all.
So they're even more of a challenging response then to me. So my point was going to be that through COVID, we had the Chief Exec's reports, which were, I think, whilst it was a huge challenge for our system, huge challenge operationally, complex challenge, it was focused on the COVID response. And I think the recognition probably internationally is that the challenge of recovering from that is even more complex and bigger than the pandemic itself. And I suppose the report itself is probably a moment in time of us moving from that COVID pandemic into working out how we recover all of our services and all of our systems, which all integrate together. And so I suppose you can see pressures in each element of our business in the way that we provide services for patients. So I suppose, yes, as the Chair, you've said, the intention was to be as open as possible about the operational challenges that we face and the things we're doing creatively to try to address the experience the public have of our services at the moment. And at this moment in time, we wanted to be as open as possible. But of course, yeah, we'll reflect on comments of Judith, Paul and Maria when we go into updates for the next board.
Thanks, Phil. Many thanks. And are the board happy to receive the operational report and update? And thank you, Keith and Jill, and Andrew in his absence. If we now go on to the update on the review of paediatric services, and that's Phil.
Thank you, Chair. So we recognise there's considerable public interest in this work, and we wanted to give an update on the work that we're doing around the review of paediatric services. It's important to note, as you'll see in the paper, what we agreed on in September in terms of supporting the extension of the temporary service arrangements until the review had been concluded, and also the point that we would support a collaborative review of the temporary service change with our Community Health Council from March 2022. So this paper describes the governance and some of the advice that we've received, particularly working with the Consultation Institute, and the implications on the timelines for our work this year. It also is a snapshot of some of the patient experience data that we've been collecting during this period. There is other data, but I intended to hand over to Lee, who's been supporting the planning of this, perhaps just to highlight some of the key areas just before we take questions.
Thank you, Lee.
Thank you, Chair. Thank you, Phil. Yeah, so Phil's covered much of it really. So it is an update paper, just to appraise the board of where we've got to with the key approach to undertaking the review. Appendix 2 set out the key milestones, which I think are important, and as Phil says, we've got some examples of information that we have available to us, which we collect on a regular basis, and will contribute to the review. I guess the three key points that I just pick out is for board to be aware of is that we are, as part of the review, having looked at it, we've decided to include all of the changes going back to 2014, so not just the recent change. I think that's just an important point for board to be aware of. That does have an implication inevitably for the scope of the work and what we intend to do through that process. Secondly, we are undergoing undertaking this work in partnership with the CHC, and as Phil says, taking the advice of the Consultation Institute on how to set out this process. So, and then finally, just to get reassure the board, I guess, building on some of the comments we've made earlier in previous items, that it's very important, as Phil says, given the level of interest in and how important the service is to the population, that we are transparent in the way we undertake the review, and that we're engaging our public and involving our public in reviewing what has gone before, how we've got to this position, if you like, and what the options might be going forward. So that's a key principle for us as we undertake the review, and we'll certainly be updating the board over the coming months in that regard. Thank you.
Thank you, Lee. Can I open for questions or comments? Delith?
Thank you, Chair. Thank you, Lee. As you would expect, I will be asking a question about children and young people, and children and young people deserve the right to be treated and the standard of care to be high, but also you need to balance the need of providing safe urgent care for that population, but you also need to take local needs into account. So how have you engaged, or how are you planning to engage with parents and carers and families, and have you looked at good examples or good practice of rural urgent care, and have you involved the Royal College in this discussion at all, as well as our local clinicians and GPs and WAST?
Do you want me to come in there, Phil? So on the points of parents and children themselves and families, so there's two stages to this. The first is the consideration of the issues paper as we're describing it, which is to understand the implications and the changes that we've made over the past 8 years in total, and get clinical voices and parent and children voices into that, so we can do that early engagement to lead to that issues paper. And then as part of the options appraisal, we'll be building further on that. So what we're envisaging doing is something equivalent to what we've done with the land selection process that I talked about earlier, where we'd be running independently facilitated workshops with patient and parent and public representation as part of that, and then as we will then in addition be including partner organisations like WAST, as you've mentioned there, Del. They'll certainly be important to that. So that will be the process for assessing those options and undertaking the issues paper. Your point about reviewing examples of others, we haven't done that at this stage, but certainly that's going to contribute to the options appraisal that we'll be undertaking later in the year. And we have had Royal College input previously, I believe, and Phil might be able to advise more on that. We haven't at this stage we haven't intended at this stage to include the Royal College formally in that process, but Phil, you might want to offer an opinion on that as to whether we would like to do that or not.
Yes, I can. I was trying to type that I have comments. Yeah, we've had at least 2, I think 3 Royal College reviews, and at least one of them was joint with other colleges, including the Royal College of Obstetricians and Gynecology and Royal College of Nursing, and we had strong midwifery input into that. So we have got some really strong pointers from the Royal College about our model. We're taking that information very much into account. Now, it may be that through the process we go through that we need to go back to the college and ask them questions. At the moment, though, I think we need to keep that option open, and we need to run the process as openly as we can do with that information in mind.
Thank you, Phil. If I could bring in Paul, please.
Thank you, Maria. Yeah, a couple of queries really in relation to the report. The survey data which you've included with the report is for the period 2nd of September to the 30th of November. Is there a particular reason why it's only for that period and there isn't anything for a longer period and more up to date? And secondly, in relation to the deliverables, the final bullet point where we place in the horizon as being the establishment of the new hospital. a query really as to whether that would be the appropriate horizon to ask the board to consider approving any change, because it seems to me that although we may be optimistic about the decision to create and build a new hospital, we can't be certain about that, and we may not be certain about that by November, and therefore should we be looking at some different horizon, possibly at the point in time when a decision is made about the funding or building of a new hospital.
Okay, if I take both of those, then so the first point on the survey data, so that's as Phil says, that's an example of the data that we are routinely collecting. So it is continuing to go, it continues to go on and will continue to go on, Paul. So it was just that that period had been analysed at this point in order to give board a sense of the type of data that we've got. The intention is to look at a full 12 months of that data in more detail as part of the review, so we get a more comprehensive picture. And actually, because it's an all-Wales survey and has been going for a number of years, we could potentially go back further as well to get some longer term analysis of that done. So that was the only reason that it was restricted to those 3 months. On the second point, so the reason it's phrased in that way is, I guess from a strategic point of view, we've got a direction of travel in relation to the new hospital and the strategy, which is effectively a fixed point. Granted, we're not certain that will be the outcome yet, of course. But that is where we're working towards. So this is more about being clear that is already set out in the strategy in terms of the plans. We're not looking to change that longer term strategic plan. What we're looking to do is agree a sustainable position between now and then, whatever that date may be. Now that in itself, as you rightly point out, will be long term, because that even on our current timetable is 7 years away. I guess what we weren't intending to do was come up with a set of proposals that would be only for a short period. So whether that's a year or 2 years, again, we wanted to set out what that long-term interim arrangement would be up until the point of the strategy. So I guess happy for us to have further discussions about what we might want to do with that in November, and that might be subject to where we get to on the PBC discussions. But certainly our intention was to come to a set of options to span from today, or from that point, or the point of implementation rather, through to the new hospital.
Yeah, on that point, I don't want it to sort of be a semantic discussion, but if we're talking about until the establishment of the new hospital, then that's an horizon that we may never get to. And so I think if we need to be clear, I think, as to what the end point would be, as to what period of time we are making this change for, and if we time limit it or have some other criteria which is more within our gift, that would seem to be need to be more appropriate rather than something which is probably not within our gift anyway. As maybe we don't need to have that decision now, but I think it is something that we need to reflect upon between now and the outcome of the exercise which you're undertaking, and when this may come back in November for further discussion.
And there can be an either or, you know, new hospital or 2029, which is the period of the new hospital.
Yeah.
Just to make it clearer, it's not based solely on something that may not happen. That's basically what you're saying. If you could give that some thought, Lee, please. I'm going to bring in Mansell.
Yeah, thank you, Chair, and thank you, Lee, for that. I'm just looking at the pie charts, really, and I just wondered whether there's more detail in looking at patients who are being transferred from Withybush up to the PACU in Glangwili, and also patients in Pembrokeshire who actually go straight to PACU in Glangwili, knowing that there's no service at the moment in Pembrokeshire. And I just wonder if you're going into more detail on that. These are quite generic, you know, have you been transferred? Yes. And there are certain comments, But I'm just wondering if there's more detail going into those surveys for the residents of Pembrokeshire. Thank you.
Yes, that is correct, Mansell. So what's presented is, as you say, for the health board and is a generic survey. What we do want to do through this is get the personal experiences of individuals who have had to access the services in the way you described, so either directly or transfers, as you say. So I think it will be important for us to get their personal experiences systematically, but also then have some personal stories that can add a bit of detail to that and engage with individuals, so we can understand properly what their experiences was. And we have been getting some of those stories back into the system, and we'll analyse those appropriately. But certainly it will be important over the next few months to build on that further and get those stories and voices into the process. Thank you.
In relation to the data that we have collected so far, and we will be collecting, could we ensure that, as we do at the patient experience report, you said we did, that we're actually taking action in relation to some of the patient experience now? So looking at some of the data that we've got already, obviously the travelling time is something that we can't influence at the moment, but we can influence the experience of waiting in A&E for children. We can experience vending machines and appropriate refreshments for parents within Glangwili on Kilgerran Ward. So I just want to ensure that as this is ongoing, we are improving patient experience.
Yeah, thanks, Mary. So we're going to work much more closely now, I think, with the patient experience team on how we do that, because obviously they've got useful experience in that and data sources. So I agree through this process, and it refers back to some of the comments and questions earlier in the patient experience report. We'll be working with the teams to take that feedback and see what we can do in the short term to improve services.
Thank you. Delith has a comment she'd like to ask: how are we maintaining the conversation with families and ensuring up-to-date information is given throughout? Hold on a second, it's given throughout. You can see the comment. The process to alleviate fear and signpost for advice, information and close working relationships with primary care. There's also another comment from Delith about being able to afford the journeys. I know when I was in my past life, we had a Pembrokeshire fund for travel fund for sick children. It was a local charity. I don't know if it exists anymore. Yeah, a comment from Sean. I don't know if you can pick up Delith's comments, and I know Phil wants to come in as well.
Do you want me to come in, Maria?
Yeah, yes, please.
Yeah, I think this is a really, really important point around the journey that a sick child makes, and I think it's recognising who's sick early on in the patient pathway. That as soon as they pick up the phone to the triage doctor, that they ask the right questions. I've been in this situation myself where there was a family who couldn't afford the journey to Carmarthen, and I called the exec on call and arranged transportation via the health board for that child. So I think that's it was a really good asset to have up your sleeve when it was after midnight, when you were working. So I think that's an important point to raise, that we should provide transport.
Yeah,
if transport is not possible for people. But I think the key thing is recognizing that a child is ill and making sure they go to the most appropriate place for their care. So if they're not that unwell, then they can be seen by a GP in Pembrokeshire. But if they're not well and need admission, then we need to convey them to the safest place where we can deliver care.
Yeah, and we need to communicate that both to the GPs, don't we, and to families, that is available. Okay, Phil, did you want to come in?
Yeah, I mean, I was actually going to try and make a point about Paul's point earlier, but on this point, I think we can take these points that Delith has made back to the group, because we did have discussion in September about our concerns about families being able to afford to either get to Glangwili or back from Glangwili. In a way, getting back from Glangwili, it's sort of there's a sort of it's easier for people to raise that at that point in time while they're in Glangwili because they've got nurses around them. Whereas if they're at home, it's having a way of them being able to raise that at the point of referral when they want to get to Glangwili. So we'll take that back to the group, and I suppose the other point you raise about how we're keeping families involved, I think that needs to be picked up through our the process that we have in place through the engagement process we have in place in the coming months, and we just need to I think hopefully we will involve enough people within that so that of course we will be targeting families with children. I think on Paul's point, and on reflection, maybe this is an obvious point, but the reason our whole strategy is for acute services is based on us having a new build in between Narberth and St Clair's is that other configurations, and we did look up to 32 of them, were felt to be less safe, sustainable, accessible and kind. And I suppose so other options are going to be I suppose not as optimal as the option that is our strategy. And we took a long time developing that strategy. So I suppose this is why we're describing this as an interim model, because we believe that there would be a better way and a more safe, sustainable, accessible and kind service, which would be to have a new hospital. I take the point though that some of that is out with our gift, but it's important that we recognise that is what we that is what our strategy is, and we believe that would provide better, safe, sustainable, accessible and kind care.
Yeah, thanks, Phil. And I think in relation to the interim, it's about making it as also, as we've said in the message bar, accommodation, transport, the facilities as friendly and as accessible as possible whilst this process takes place.
We need to apply exactly the same principles of safe, accessible, safe, accessible and kind care.
Yeah. Okay.
Maybe could I just say I accept all those comments and arguments as to why we came to what the strategy is. But as we said earlier, we do have to recognise that the building of the new hospital and that solution is not within our gift, and to sort of pin our decision to that outcome is not doesn't feel right to me at the moment anyway. We need to have an informed discussion, I think, when we get to that point in November as to what the options may be.
I think that's a wise suggestion, and that when we come back we'll have those options available. Yeah. Okay, thank you. On that basis, with those caveats, are the board happy to accept the recommendation? Thank you very much. The next item on the agenda is the Integrated Performance Assurance Report. We are running late, so I'm going to ask people if they could keep their comments as concise as possible. But those papers that we have discussed have been really important. So over to you, Hugh.
Cadeirydd, diolch. And I will keep it brief in the interest of time, recognising that I think the operational update that the board received actually addresses many of the issues that have been highlighted in the performance report, in particular the quantitative finance report. The month 12 report is there just for information. Happy to take any questions on that, but it's there as a log and a final report from last year. I'll just spend a little bit of time on the month 1 report. We've again made a few changes to this report just to highlight some of the initiatives and improvements that have impacted our performance, which are highlighted on page 3, virtual appointments, waiting list validation and dietetics in particular. And then a number of activities which have been undertaken and initiatives which we haven't been able to see the direct impact on our performance as yet, largely because of the increased length of stay we're seeing. So same day emergency care, some great work going on there, and breaking new ground across Wales there in that space. And same with ambulance triage, and much work going on in primary care as well. The report speaks for itself on the impact of that, but clearly not demonstrating in performance as yet. And then on page 4, I've highlighted the key issues that we're seeing impacting on our performance. These are fairly consistent with what I've reported previously. I have included an initial draft on page 5 of the key improvement measures which we as an exec team have agreed for 22-23, recognising that some of the trajectories for these are in draft and will be refined as we go through the year, and some of the particularly around integrated localities, urgent emergency care, there is more work that we need to do to understand what exactly is the performance measure that we are trying to capture, and how we then capture that. So there's the mechanics before I can bring something more robust back to the board, Chair. I won't go through the rest of the report on the basis that we've had the discussion.
Yeah, thanks, Hugh. And in relation to our performance trajectories, when do we expect all of them to come before us? Would that be next board meeting?
We very much hope so, yes.
Thank you. Open to questions, please.
Could I come in, please? Thank you. Just a couple, please, if I may, Hugh. I guess, you know, it's really stand out on page 4 that under the mental health about the assessments for the under 18s. I think that is worse. In fact, I think that's the worst I've seen it. So, you know, I just would maybe when we have the trajectories, just understand what the performance trajectory is for that. The other one I'd like to raise is on page 5, which is the dental care, which we don't really discuss very much at all in terms of performance, but it, as everybody will be aware, it's certainly sort of hitting the headlines quite a lot at the moment. So I think maybe not at this committee, not at the board, but maybe other committee, it would be good to have an understanding of the full position with regard to dental care. I probably know quite a bit from my discussions with Jill, but I think from the point of view of the board understanding where we are with that, it would be helpful.
Great. Yes, thank you. I can see that Jill has come in on dental in terms of mental health. I appreciate the challenge, and I'll bring something back in the next report, but I appreciate this is an area that's getting quite a lot of scrutiny through the subcommittees too.
Jill?
Yes, thank you. And I won't, as I say, extend the conversation now, but we are seeing that increased level of demand in terms of our urgent dental care services. We're also undergoing a complex contract reform process whereby practices are having to determine whether they remain with the extant UDA process or move to a more targeted model of need. And 80% of our practices have agreed to move to the new model. So we will bring an update because I think it's, as you say, very topical in terms of the delays in being able to access NHS dental services, and that is resulting in that consequent demand for our urgent care services. So I'll happily do that in the relevant committee.
Thanks, Jill. And can we discuss outside of this whether it should come to board a separate report on dental services, please? Thank you. Any other questions?
I think John wants to come in.
Complete, John.
Chair, if I can just make a comment more than anything, just to echo Judith's point around the data that we've got around mental health, which is obviously of concern. But the other issue, which is quite noticeable in this report and in the month 12, is not only the increase in demand that we're seeing, but the increase in the complexity of that demand and the acuity. And if we look at the figures, there's almost a doubling of the acuity. So we're not only having to deal with increased numbers, but the complexity and acuity of that means that our services are clearly facing quite complex demands. And that is something we need to think about in terms of patients, but equally the impact on staff having to deal with this and the impact that it has on them. Thank you.
Thank you, John. And there's lots of nods there in accordance with the data. Are there any other questions? Mansell, did you want to come in on this?
Yes, please, Chair. Thank you. And thank you, Hugh. Just a quick question on the cancer target. I noticed it was 57% at that time. Is that due to out of area treatment mostly, and if so, what's happening with that? And are you communicating with patients accordingly, like they're doing in the elective process?
Yeah, if I pick that up. Yeah, thanks, Mansell. No, so just for contextual understanding then, so we managed to improve our performance to 57% in the last reporting month, after a period where we dipped below that 50% mark over the last couple of months. So broadly, if we think back historically, we've had a significant concern, and we continue to have a concern about pressure on some of those tertiary treatment pathways. However, I think we have to be fair and realistic that, again, it's a phenomenon that's built up pretty much through the pandemic period, that we are now experiencing delays at the front end of our pathways through the outpatient and diagnostic phase that outweigh the impact of that tertiary problem at the present time. Yeah, so in fairness, we have to be honest to ourselves here and really focus down on our recovery plan to improve the diagnostic part of our pathway. And we've spent the last couple of months trying to develop a recovery plan that sits around that, Mansell, and have now developed some clear trajectories for, on the one hand, reduction of the backlogs that have built up, if you like, given the pressures on those services throughout the period we're referring to, but also then the extent to which the reduction in those backlogs will then start to contribute to further step improvement in our cancer pathway performance. So there's a huge piece of work that sits behind that, and we've been doing work with Welsh Government and others just to nail those forecasts, if you like, pathway by pathway, so that we've got a very clear set of actions and trajectories that support that. Yeah. I would say, and it's important for us to recognise, that we are likely to see some variable performance for the next few months on our cancer pathway, and that's a phenomenon of the way in which the cancer pathway works, because of course patients breach in the month that they are treated. So as we progress our plan to clear the backlog, those patients will graduate to treatment beyond their target date. So we'll have a bumpy period for a few months before that starts to step up in an improved way. And in terms of the communication bit, Mansell, yes, there's a targeted piece of work there. Not so much through our waiting list support service function, but more through our cancer nurse specialists and the nurse specialists in each pathway to maintain communication with the patients on the pathway.
That's very reassuring. Thank you, Keith. Thank you, Chair.
Thank you. And Winston's asked a question, can we confirm our vacancies level? Lisa.
Yeah, so as at the report that we produced a few days ago, our current vacancies are 742 whole-time equivalent. They're predominantly made up of nursing vacancies, which are 470, followed by our medical workforce 327. It's then other staff groups. So that is an improved position from previous reporting, but still a significant number for the Health Board.
Thanks, Lisa. I think it was 950 before, wasn't it? That's good to hear.
Yeah, so this is, sorry, the vacancy rate that we use is establishment versus staff in post, not what's going through the system.
Many thanks. Are there any other questions on the report? Thank you. And as you said, Hugh, we had discussed a lot of the performance previously. So diolch yn fawr. If we can, everybody happy to accept the recommendation? Thank you. If we can now go on to the financial report, month one.
Thank you, Chair. I'll just go through very briefly last year's position, because I think we've addressed that, and just to confirm that we are going through the audit now. Draft position is a 25 million deficit that was predicated upon a significant level of non-recurrent funding. There was 32 million pounds worth of stability funding that was provided, and 32 million to support the underlying position. And clearly, as I highlighted through last year, that was going to become an issue for us in terms of our underlying position going into this year. On track in terms of audit, and we've got our board meeting, I think 9th of June, coming up to approve the accounts. So if I spend more time then on this year's position, and start with the in-month position that we've seen in month one, and the in-month position is a 4.4 million pounds overspend position, of which 2.1 million relates to our deficit plan. We planned for 25 million in the initial plan that was presented at the end of March, but as I highlighted that at that point, we didn't have sufficient, so I didn't have sufficient assurance at that point that our forecast would be any better than 42 million, and indeed we are seeing the impact of unidentified savings coming in month one. We've had 1.4 million of unidentified savings contributing to that 4.4 million overspend. And we've also seen operational pressures continuing, and that challenge has added another 900,000 to the position. Of that, about 300,000 relates to the enhanced pay rates that were agreed, and that's obviously contributed to the challenge. But having said that, we did see a reduction in nurse agency within month one as well. And I think the biggest contributor to the position is that we had agreed that non-recurrently, and for this year there'd be a handling process whereby the totality of the operational pressures would be managed, so the underspends within the operational teams would be offset by the overspends, and we have seen an increase in those areas that were underspending last year. So mental health, for instance, has increased its spend rate and much closer to budget, and likewise planned care. Those are two big areas of change. So the in-month performance clearly represents a concern, and it's a concern against that initial forecast I presented of 42 million. So I think there is a risk against that position in itself. And clearly the main impact is the savings challenge that we're seeing, and the lack of delivery now against that savings challenge. Just for assurance for the board, we have gone through a process of a deep dive from the Finance Delivery Unit to understand our numbers, and that session was earlier this week or last week, and we've got the results of that, and I will share that with the Sustainable Resources Committee at our next meeting. But broadly consistent view in terms of the figures that we're presenting and the challenges that we're presenting, and a consistent outlook that our biggest challenge now is going to be delivering change against our target operating model. I'll just come on to some of the drivers to our position and the reason for the criticality now of our target operating model. So there are two fundamental challenges that we are grappling with. The first is the demand on our services, and the performance report highlighted that there were 119 patients in our beds ready to leave. And of course, that's a fairly consistent figure that we're seeing, and the number of medically optimised patients is at 250 at any point in time. Now, that's a significant level of our bed capacity. In addition to that, there are about 22 patients being cared for in the community waiting for their long-term packages of care, which is not only, excuse me, not only a direct cost and challenge for our staff in the community, but also means that they're unable to then support our acute sites as effectively in taking further patients out and providing providing greater assurance of the flow. That's got a significant financial impact for us. The second big item is largely down to supply of staff. And we are currently seeing about a 13 million overspend over base budgets on agency staff, and that's split between 9 million relating to nurse agency as a premium over budgets, and 4 million on locum medical staff as a premium over base budgets. Now that's partly related to that demand challenge, but partly related to some of the configuration of services and the fragility of services we are managing. So, and that indeed is why the target operating model is so crucial for us. We are taking action, and I can say that our COVID anticipated spend has been reducing steadily and significantly from our initial plan, and that at least provides some assurance that the totality of our spend is being managed, and that we are working with colleagues in Welsh Government. While that is a directly funded, or while those costs are directly funded by government, it's clearly there's an imperative for us to manage that down as appropriate in a risk balanced approach. And we are working now with our directorates quite actively on identifying further technical opportunities, but they are largely going to be about mitigating some of that pressure that we're seeing in the system, rather than addressing the root causes of that, which I think the target operating model is crucial in doing. And the last point I want to make, Chair, before I open up to any comments, is that at the end of month one, we did go overdrawn as a health board. It's a very rare thing to happen, and it was a time difference between emergency funding coming down from Welsh Government and coming into our bank account. I have informed Welsh Government and the Director of Finance in Welsh Government, and I have instructed the team to pull together a root cause analysis that we will take through to audit committee to make sure that we learn the lessons from why that happened and make sure it doesn't happen again. It was only a matter of a couple of days, but clearly an unacceptable position for us to be in. Chair, happy to open up for questions.
Many thanks, Hugh. Open for questions, please. Okay, well, obviously, we understand the financial situation and the challenges that you've explained really well, both in month one and month two. And Gareth is coming in. Gareth.
Thank you, Hugh. But a very clear report. You know, the situation is quite stark. Can I take us back to the Chief Executive's report? There was mention of that new planning objective of expanding community response there. The finance regarding that, is there any clarity whether that is any additional finance, or how are health boards expected to undertake that investment? I think it was a figure of 120 beds, so if you link that into the 119, I think you said that was ready to leave, you can see the logic in how that could release the system. I'm just wondering any indications with regards to the budget aspect.
Chair, thank you. Yes, and a significant amount of that has already been allocated. So there was 5.8 million, I think, allocated as part of the urgent emergency care funding through the way in which we set budget at the start of the year. There's a slight top up required to that, working through that with the team now, but in the order of a few £100,000. And then there is an ongoing discussion now around how we support taking patients back out into the community. So the urgent emergency care is largely about how do we provide further services in the community to prevent the need for people to come into our hospitals. There's more work to be done over that tail end. How do we take patients home into or into other packages of care? That's the bit that we need to mop up now, work through as part of the target operating model conversation. So it's all aligned.
It's all linked.
I don't have an indication yet on the budget requirement to do that, and that's what the team are working through.
Thank you. And joining a few more dots, are there linkages here with the funding that's being managed by the RPP, for instance?
Indeed, yes, and that support that's being provided through the RIF funding through the RPB is a clearly an inherent part of that whole health and social care system. So yes, there is a link across.
Diolch, thank you.
Thanks, Gareth. Diolch. Anybody else would like to ask any questions? Okay, thank you, Hugh. The board has noted the finance report and all the challenges that lay ahead of us, but we have a clear understanding of what they are. So diolch yn fawr. We're going to now go on to the LTA values and process for 22-23. That's you.
Thank you. Yes, thank you. Sorry, I was fumbling with my mic button. Chair, the paper I hope is clear. The board is asked to ratify and endorse the process that we are following. I'll just highlight a couple of issues, if I may, for the board. We've reached, and we're in a process of transition. Much as this year is a challenge for us, it's been a challenge in the commissioning space with our key providers across Wales as well. And we have, I think, agreed a package of measures here that is fairly proportionate in the way in which the risks and benefits sit with both commissioner and provider. This has been agreed across Wales, and we've got a process in place of being able to claw back any funding below 90% of the threshold, and that comes back to us at a marginal rate. But we have agreed some elements to remain on block because that drives the right behaviours across the system. So, for instance, outpatients is on a block contract, and that means that there's a real incentive for our providers to really maximise the benefit of digital adoption, which does have a benefit to our population, given the remoteness and the need to travel to some of our more specialist providers. And we've also working to disentangle the impact of high cost drugs on our main tariffs with our providers, and there's an opportunity for us to then work with our providers to really understand the impact of high cost drugs on their budgets and what we are then willing to commission as a result. So we'll work with our partners through this year on that. And I think this year is very much a transition year as we move into what's probably going to develop into a value-based commissioning framework for the long term.
Thank you, Hugh. Any questions? The board happy to ratify and endorse the LTA, resource allocation and approach? Thank you, diolch. Next item on the agenda is the Strategic Enabling Group update.
Gotcha, and another update here for the board on the latest meeting of the Strategic Enabling Group. I think we're getting to a stage where, having had a number of discussions, and I'm very grateful to members of SEG for supporting and challenging our approach on value-based healthcare, on social value in particular, on our developing intelligence offering to the health board and how we use data science to drive that, and on our approach for continuous improvement through improving together. And the last meeting that we had was mainly around workforce and organisational development based on HR Disrupted. A really good and rich conversation there. I think we're now getting to a stage where we need to review what we're doing through SEG and think about the way in which that contributes to the ongoing way in which we need to support the organisation's change journey. So with that, Chair, happy to open to questions.
Thank you, Hugh. Any questions on the update? I think that the committee, the board would endorse about reviewing about adding value to the organisation as well. I think some of the comments in the pre-meet reflected that. Okay, thank you. The board's happy to receive that report. We now go on to the business case for Cross Hands, the outline business case. And Lee, that's you.
Yep, thank you, Chair. Pleased to present this business case to the board today. Members will know that this has been a long-standing ambition for the Health Board and a key proposal within our strategy. The previous outline business case was approved by board in November 29, so this is an updated version of that of that case. Unfortunately, of course, it was the planning was disrupted during the pandemic, so we've had to come back to this over the last year or so. There were two specific points that Welsh Government raised with us at the time that outline business case was submitted. The first was on revenue, and then the second shortly afterwards was around how we looked to incorporate decarbonisation in proposals into the plan. So the paper updates on what we've done as a result of reviewing the outline business case. The key points to note are we've changed the scope slightly so that ophthalmology has been removed, and we've now proposing developing an early years centre for the area. Obviously, of course, we've made improvements or proposing improvements to support decarbonisation as per that proposal, that recommendation from Welsh Government, sorry, and the revenue impact has been reviewed and revised, so it's now cost neutral. The only other point to note then is, of course, that the capital costs have been revised and have increased. Members will note quite significantly, in part because of the increasing costs over the period. So at that, with that, Chair, I'm happy to receive any comments or questions. Thank you.
Many thanks, Lee. If I could bring in Gareth first to declare an interest.
Thank you, Chair. Yes, I should have declared it at the beginning of the meeting, but I'll declare it now at the start because I'm a member and recently appointed a cabinet member in Carmarthenshire County Council. There's a direct interest here with the Wellbeing Centre, so I won't take any part in the debate, Chair. I will
Gareth.
For the record, and I won't take any part of the debate.
Many thanks. Thank you. Going to bring in Judith and then Winston.
Yes, thank you. I really welcome seeing this coming back in this format. It's having been sort of involved in very early stages of moving this business case forward. So I really welcome that. I have just one question for assurance, really, that the team are learning from the lessons from the Cardigan Integrated Care Centre, particularly around moving different parts of the organisation and other partners into a single building and ensuring that becomes an integrated building without any invisible or visible walls or barriers. So that's one. And then, as I will no longer be on the board when this is opened, can I have an invite to its opening, please?
On the second point, absolutely, and excuse me, sorry. On the first point, so yeah, important question. We have formally reviewed the Cardigans Integrated Care Centre and very positive reflections from that experience, but some key learning points as well, particularly as you suggest in relation to bringing the teams together. So my team have obviously been involved in both this business case and the Cardigan Integrated Care Centre development. So there's a connection there, and they're certainly learning from that experience. It is, of course, necessary to note that we are bringing together some teams here, and the GP practices are part of the development. So we have to work within some of the constraints and limitations around that. So, but certainly the learning is being fed into that process. So thank you.
Thanks, Lee. If I can bring in Winston, please.
Yeah, thanks for an update on this. So this business case hasn't been to Sustainable Resources Committee, so please forgive me for any questions I might have in relation to the money side. So you said that on the revenue side it was cost neutral, but the capital costs have increased significantly. So I assume therefore that the ongoing maintenance and capital costs are picked up by Welsh Government. I'm just thinking in terms of, as a health board, us making sure that we are not incurring additional costs in the future.
Hugh, I see you've appeared on the screen. Would you like to take that?
Absolutely, thank you. Yeah, in terms of capital costs, the capital costs in general, so the cost of capital and depreciation would be approved by Welsh Government as part of approving the business case in its entirety. So the funding will flow in accordance with that. So the change in the capital cost doesn't therefore impact the Health Board. It will impact clearly on Welsh Government in terms of estates and ongoing costs and maintenance costs. You know, there is an impact there. Whether that's directly attributable is a moot point, but the case in its entirety now does hang together in terms of the revenue implications.
And just to follow up with Chair, if I may, so have we done any sensitivity analysis just in case from between now and when it's approved, what those changing costs might be? You don't have to answer now because we can always pick it up in Sustainable Resources Committee or the other or strategic development, because normally with business cases there's normally a we should just have a look at the risks of cost increasing or decreasing and just have an idea as to what we're picking up as a Health Board. You don't have to answer that now. I just wanted to make sure that we're aware of it as a Health Board.
I think there's a growing risk across all long-term capital schemes that we will see inflationary impact on it, and I think that's something we have to be very open to and manage quite closely with government along the way. I don't know if you've got anything else to say, Lee, but I think it's just a matter of working with Welsh Government on that through the development now.
Thank you. No, that's fine. Thank you.
The only thing I will add, not on that point itself, but on the point about the committee. So I should have said in my introduction that we did take quite a detailed presentation through the Strategic Development Committee ahead of coming to board today. So just for members to be aware of that. Thank you.
Thank you. Thanks for that.
That's great. That's assuring. Are there any other questions? Well, I can just say it's really exciting that we've got to this stage. It's part of our programme business case, taking care out to our communities. And yeah, we'd all like an invite, as with Judith, if we may, once it's up and running. But so the board asked to approve the proposed Cross Hands Health and Wellbeing Centre outline business case for submission to Welsh Government, as well as noting the other things in the recommendation. Excellent. Thanks, Lee. Diolch yn fawr. So the next item on the agenda are the statutory partnership updates. Is that right? Joe, is that right?
It could be Winston next, Chair.
Oh, excuse me, Winston next. Sustainable Development. Excuse me. Sustainable Resources Committee.
Thank you, Chair. It has been a long meeting. I'd just like to say we met in April, and we also had a checkpoints meeting with the Director of Finance a couple of days ago. Hence earlier we didn't feel we needed to comment on his report, which was quite clear. I think the report itself speaks for itself. We talked in particular about the operating model, and our key thing just for the board's attention is our keenness that the organisation established what the new operating model is, because that in itself will help us towards getting to a balanced IMTP and the balanced budget. So that's all I wanted to highlight at this point.
Thanks very much, Winston. I just got a couple of questions, if I may. There are two issues on page 4. One was the feedback of the questionnaire in relation to the spinal surgery in Swansea Bay, and I just wondered if one of the officers could tell me where that's going to go to. And then the other one was the outcome of the investigation in relation to the CHC, Community Health and Eye Care provision at Bridgend. When is that conclude? Well, it says it's concluded by the 5th of May. Where will the outcome be considered?
So, Chair, I think the best person to answer that may be Hugh, the Director of Finance.
So I was fumbling with buttons. I think I'm going to ask Keith to come in, given Keith's just come on the screen to answer. I'm afraid I'm not sure when the changes are.
Okay, Keith.
Sorry, Chair. So that process has now been concluded, and the investigation journey of our patients back to that service has recommenced. Yeah.
Okay. Okay. So where will the investigation be seen by in the committee structure?
Through the operational quality committee in the first instance, and then
Okay.
reported upwards through the structure.
Quasar, okay. And the one about the spinal patients, the patient feedback, well, that goes to Quasar as well as patient experience.
That would be my expectation, yes, Chair.
Okay, that's grand. Thank you. Any other questions on this report? Well, okay, thanks very much, Winston. So the next report is the Strategic Development and Operational Delivery Committee.
Thank you, Chair. Nothing really to highlight. Just like to say that we did approve the delay in the presentation of the risk management strategy, but that is now out to consultation as of this week. But other than that, I'll happily take questions.
Thanks, Winston. Sorry, I'm losing it. Excuse me. Thanks, Maynard. Any questions? Okay. Thank you very much for the report. And then the National CHC Framework, Jill.
Yes, thank you. Very, very briefly, it's important to note this is a statutory responsibility of the Health Board. We were previously operating the 2014 framework, so there was a delay to that update. We now have the revised update, and the inclusions in the new framework are reported here. There's no material change to the issue of eligibility or quality assurance. It also does introduce some new requirements for the Health Board in relation to independent user trusts, but the governance and framework for that piece of work is still being worked through nationally, but it will offer an alternative, more flexible arrangement for the Health Board to work with individuals and families who are eligible in terms of operating that. So I would commend that to you. We have updated our systems and processes. There is a revised patient leaflet also available, and we're rolling out training across the Health Board in terms of the revised framework.
Many thanks, Jill. Are there any questions on this? Okay, is the board happy to accept the recommendation? Diolch yn fawr, thank you. Next is the report of the People Committee.
Thank you, Chair. This is an account of the meeting that was held on the 4th of April. I would wish to just draw out 2 points, if I may, Chair. One is pleased that we were able to discuss how we are going to develop an education and workforce forum in order to ensure that we address the educational needs and requirements in our workforce plans. That's a very positive development, and also the ambition of the Health Board for that to be interprofessional. So that was most welcomed. And secondly, the Welsh language strategy. And we've now got a clear timeline in terms of our ambition, not only for the Welsh language standards, but equally our role as an organisation in promoting Welsh culture within the region. And that the report then notes the timeline and the expectations that we've placed on the organisation with regards to that particular strategy. Thank you.
Thank you, John. Are there any questions at all? No, many thanks, John. So the next is the report of the Health and Safety Committee.
Yes, thank you, Chair. This is the report from the meeting on the 9th of May. I'll apologies, but my admin control system has just decided to stop working. I did want to draw attention to the progress in relation to fire and safety and the work that's been done to improve the relationship with our local fire. Sorry, I've got it back now, with the local fire authority. But after that, happy to take questions.
Many thanks, Judith. Any questions? No, thank you. It's good to see the improvements, Judith. It really is. And then if we now go to the committee update reports, is everybody happy to accept those reports at 6.5? I think there's one recommendation in the Strategic Partnership Forum, if I recall, Joe.
Well, there's one set of terms of reference to approve, Chair, but they're not here today because we'll bring them as a suite to July board when we review all terms of reference, Chair.
That's grand, thank you. And then if we go into the working in partnership, the joint committees and collaboratives, everybody happy to accept those?
Just one thing, Chair, that I can see Jill actually wants to come in. Looks like
Jill's back.
Okay. Just on the joint committees, one thing I did just want to highlight on page 3 of the report in the ESC update is the the reflection of under provider issues, the reflection of Welsh Ambulance of the pressures that they've had on from an unscheduled care system, and highlighting the sort of serious issues there, which I know we've alluded to earlier, but you can see there it's reflected from the Welsh Ambulance Service itself. And of course, the actions that we're taking all relate to try to improve ambulance response times and handover.
Thanks, Phil. And I think that the latter bullet points about the system and the flow are actually the major one that's causing all those front doors. So thanks for that. And I'm sure we will continue in partnership to try and alleviate the patient experience and the pressures on staff. Also noted on page 3, it talks about the detailed briefing issued about roster changes, the fact that they've increased, and I think there's an additional 34.5 emergency ambulances operating across Wales. It would be good to share the detail with our board so that our public and health can see the increase in provision, which will help hopefully some way towards the challenges, although unless we sort out our whole system, not necessarily so.
Yeah, thank you, Chair.
Thank you. And the next one is the board annual work plan. Everyone, oh, Jill, did you want to come in? Excuse me.
No, apologies, but I do wanted to draw the board's attention to the wellbeing assessments that were attached to the Starship Partnerships update. A wealth of information, a huge amount of work that's been done, and actually information that can help us in terms of our own business case, our population needs assessment. And if people have the time to go into those links, they will see the breadth of and scope of those assessments. So I wanted to draw that out today.
Thanks, Jill. They're absolutely fascinating. I did get the opportunity to read 2 of them. I didn't get the other one, unfortunately, but absolutely fascinating. A rich source of material for us to take into our planning and our partnerships. So thank you very much. So the annual board annual work plan, board's happy to accept that. Do you want to say anything, Joe?
No, Chair, we'll just update that again to do with any items that have been raised at today's board meeting.
Many thanks, that's great. And the date and time of the next meeting is Thursday, the 9th of June, which is the sign off of the annual accounts, and we'll discuss if anything else should be in there.
Yes,
So,
Chair.
And Sam's made a comment there, smaller geography approaches in the local assessments. We do have some data, Sam, which breaks things down into wards, but it's not necessarily these particular reports that we can share with you. So thank you, everybody. We'll have a 5-minute break and go into in-committee session, if we may. So thanks, everybody, for attending the board. Diolch yn fawr.
Thank you, Chair.
Thank you, Chair.